Good morning, everyone. I'm Katherine Henner, the Acting Director of the Office of Child and Family Services, and I would like to welcome you all to our ethics training for behavioral health clinicians. I apologize for not being on video today. I am on a cell phone and it's a little too shaky. We are delighted to have you here as we embark on a journey of professional growth and ethical awareness. This training is aimed to equip you with the knowledge and tools necessary to navigate the intricate ethical landscape of behavioral health through an intersectional framework. Throughout this program, participants will explore various ethical dilemmas and best practices that arise in the field of behavioral health. Our expert facilitators will guide you through engaging discussions, case studies, and interactive exercises, enabling you to enhance your ethical decision-making skills. Your participation in this training demonstrates your commitment to upholding the highest standards of ethical conduct within your practice. We encourage your active participation with fellow participants in sharing your insights and asking questions. Once again, we extend a warm welcome and wish you a productive and rewarding experience.
Good morning. I am Janet Imobisa, and I'm the training coordinator for the Office of Child and Family Services. Again, thank you so much for gathering with us today for our behavioral health professionals ethical practice training. It's my pleasure to introduce today's instructors for our initiative, the Behavioral Health Professional and Ethical Practice, Dr. Shante Tarver and Dr. Shanice Winfield. Dr. Shante Tarver currently serves as a tenured associate professor at Old Dominion University within the Department of Counseling and Human Services, inspiring and educating future generations of professionals within the field. In addition to her academic contributions, she co-founded and serves as the training consultant for the Human Development Group, LLC, collaborating with various agencies and organizations to strategically develop intentional and meaningful equitable practices and policies that embrace diversity and foster inclusivity. As a prolific researcher and author, Dr. Tarver has made significant contributions to the field of social work and human development. Her work includes 15 peer-reviewed articles and co-editing a groundbreaking book entitled Developing Anti-Racist Practices in the Helping Professions, Inclusive Theory, Pedagogy, and Application. These publications, along with her extensive experience, has positioned her as a sought-after speaker, having presented at numerous local, state, and national and international conferences, sharing her insights and expertise on equity, inclusion, and anti-racist practices. We also have with us today Dr. Shanice Winfield. As an assistant professor of human services at Old Dominion University, Dr. Winfield brings a wealth of expertise and knowledge to the field of addiction education and clinical practitioner competency. Through her research endeavors, she actively contributes to the scholarly canon of addiction studies, driving innovation and enhancing the quality of care provided to individuals and families affected by substance use disorders. With over 15 years of experience in the field, coupled with her academic background, she is uniquely positioned to guide and inspire future generations of behavioral health professionals. Dr. Winfield has dedicated her career to providing comprehensive substance use disorder, mental health, and play therapy services to individuals and families across the lifespan. As a highly respected expert in her field, Dr. Winfield is known for her ability to bridge the gap between theory and practice, providing practical and evidence-based strategies that empower professionals to deliver the highest quality of care to their clients. We're honored to have both Dr. Tarver and Winfield share their knowledge, insights, and expertise, guiding us towards a future of enhanced ethical practice within the clinical behavioral health field. Let's please extend a warm welcome to our instructors. And with that, I yield the floor. Thank you.
Thank you for those wonderful introductions for myself and Dr. Tarver. I'm going to jump right on in for the sake of time. As I'm talking, I do welcome questions in the chat. And after each slide, I'll provide opportunities for us to discuss any questions that came up on that particular slide. And Dr. Tarver will kind of read those questions and we'll kind of discuss them. But if there aren't any questions, we'll move right along. But I do want you all to feel engaged and provide those questions as we're going through the presentation instead of like just waiting until the absolute end of today. So with that being said, I'm going to go ahead and share my screen. And we will get started here. All right, so let me move your wonderful faces off my screen here. All right. So today we're going to be talking about three major topics, which will be understanding the ethical role of the professional and the client in behavioral health treatment. I'm a really strong believer in that you can't really understand ethics until you know who you are as a professional and that role within the professional client relationship and how it comes together when we talk about organizational ethics and all of that kind of foundational stuff. So we're going to start there, and then we're going to go into standards of practice, the difference between laws, ethical codes, and morality, and regulations. And then we're going to conclude today with talking about some common ethical decision-making models, because I understand behavioral health professional is really broad. We're not going to stick to just counseling ethical decision-making models or just human services ethical decision-making models. We're going to talk about them in a broad sense so that way you all can adapt them to your specific discipline. And again, we just did our introductions here. So we're going to start by saying who is the behavioral health professional. So this person helps meet the human needs through an interdisciplinary knowledge base. I really do believe the behavioral health professional is not one that is just counseling or just psychology or just social work. They really have to have an interdisciplinary, eclectic, interprofessional lens in order to really serve the needs of the client. I'm really big in humanistic, person-centered care. And when we think about the needs of the client as it relates to prevention, remediation of their problems, concerns, or areas of clinical need, and maintaining our commitment to them, we have to learn from other professions. We have to engage in continuing education. And then most importantly, we have to maintain our foundational identity that comes from our own specific discipline. So I like to give that definition of who is the behavioral health professional. It's not just one discipline, but a service provider that really kind of encapsulates the knowledge of all the disciplines as it relates to holistic client care. So considering that definition, we have lots of levels of education that someone can identify with being a behavioral health professional. But most importantly, they have certain skills, and we're going to talk about those in the next couple of slides that include interviewing, being able to develop, maintain interpersonal relationships with both colleagues, their supervisors, as well as the client and their support systems. They engage in family guidance, counseling. They understand that it's not just the identified client, but also that client support system and their system as a whole that may be a part of our service delivery. They also engage in group counseling, crisis intervention, policy development and understanding, research and assessment. So all of these different identities and roles kind of can fall under that behavioral health professional identity. So when we think about that definition, these are just some common roles and titles. Of course, this list is not all inclusive, but these are some of the more common roles that we will find ourselves in that we can say we are a behavioral health professional. So we have our peer specialists, which are commonly seen in the substance use disorder and addiction treatment field. We have our addiction specialists, and I put that there because it's broad, because you have your CSACs, your LSATs, your master master addiction counselors. Like there's so many different credentialing and licensing that can fall under addiction specialists. Of course, you have your human service practitioners, your behavioral analysts, your marriage and family behavioral health professionals and therapists, your psychiatrists, your psychologists, your social workers, your counselors, and we can even put school-based professionals up there as well. Within all of those roles, there are common duties and competencies as it relates to empowering our clients. Regardless of what role we have, we want to empower our clients to get to self-actualization when we think of Maslow's hierarchy of needs, to get to a place where they can function independently, where they don't need services anymore, but if they do need it, it's at a minimum level because they're able to have that autonomy and to be able to maintain stability in the community. We also communicate effectively. We assess all areas of the client's needs, even if those needs cannot be addressed in our particular agency. Adequate assessment allows us to be able to refer, be able to do linkage and monitoring, and to be able to make sure that that client is getting ethical and quality care, even if it's not 100% in our agency. We also engage in community service, networking, interprofessional collaboration, just to make sure that we know what services are out there and the client is getting that linkage as well. Of course, we execute and facilitate services. We engage in as well as facilitate education and training. We advocate for our clients, but most importantly, we teach them to self-advocate. We engage in crisis intervention. I feel like that is just as important as our traditional service delivery, to be able to respond to crisis effectively and demonstrate crisis intervention skills with our clients. And then most importantly, the hallmark of our field is documentation. One of the things that was kind of embedded when I started in the field is that if it's not documented, it never happened. So that is something I'll be talking about when we think about ethics, when we think about the law, and how our documentation really helps us navigate lawsuits, ethical dilemmas, things where harm may have been alleged towards a client. There's so many different things where our documentation is important. So before I move to the next slide, are there any questions or comments? Nope. Okay. So let's look at some characteristics of an effective behavioral health professional. There are certain things that have to be embedded in our personality in order for us to be effective behavioral health professionals, to be able to have the humanistic spirit, so to speak, that allows us to adapt ethically, to be able to provide ethical and quality service delivery, and to be able to do the work that we do in a way that really benefits the client. So one of those things are our ability to develop relationships. The relationship between the helper and the client is the biggest factor in fostering client change. When we hear, for example, I sit as the president on the VCB board, and we do look at ethical dilemmas and challenges. We look at complaints from different things. And one of the things we look at from client complaints, it's rooted in the relationship, feeling violated, feeling mistreated, and that kind of leads to other things from there. But the relationship between the helper and the client is the biggest thing that is rooted in our ethical decision-making. It's rooted in our ethical service delivery. It's one of the things that can make or break whether or not the client stays in services. They always say first impressions are lasting. And if you can really foster that relationship with the client at that first contact, you get that buy-in that leads to those service planning, that leads to assessments where the client discloses enough information for us to adequately diagnose and do service linking and all those other things that really helps move the client along to discharge. It starts with clients feeling as if we care about them. So an effective behavioral health professional would be one that is able to develop relationships with the client. Sorry, I have the chat just popped up. Let me reduce that there. All right, next will be empathy, which is very different from sympathy. Empathy is the ability to understand the inner world of another. Sympathy should not be confused with empathy. Sympathy is when we feel sorry for them. I feel like sympathy leads more to ethical violations, because when we feel sorry for someone, we tend to lean towards morality. And that's when we start questioning ethical codes and what we should do with what we want to do. And I'm going to talk about the differences between morality, ethics, and the law in a few slides down. But empathy is the ability to understand the inner world of another, to be able to hear what the client is conveying and to be able to understand it. Empathy is it's a funny thing because we need it to provide ethical services, but at the same time, we don't want to have so much empathy to where we are now having countertransference, to where we're now taking on the client's challenges as if they are our own, because then we start operating in a way that may be unethical. So we'll talk about that later today as well. Being genuine, being in sync with our own feelings, our own behaviors, understanding what our limitations are, and genuinely doing the work because we care about the well-being of others. This is not a field where you would go in just because you want a paycheck. I tell my students that all the time. You have to be genuine. You have to have an earnest heart to get into this field, because you're going to hear and encounter and really work with individuals that are experiencing some really hard challenges in life. And if you're not in it for the right reasons, you're going to get burned out. You're going to engage in unethical conduct. You may make decisions that cause harm because you're not being genuine with yourself as well as with the client. So being genuine is really important, genuine with ourselves, and then that kind of translates over into our service delivery with the clients. And then cognitive complexity. This is the ability to understand, let me move this little chat part here, the ability to understand the world and your clients, to be able to think outside of the box, think outside of my worldview, be open-minded, to be more effective, and to get involved with the client's world, but not so involved to where we're making decisions for them. We're directing things for them, and the client is now codependent. So we're able to operate within our own world outside of the office. We're able to recognize our strengths, our limitations, and really grow ourselves, but we're also able to understand the world of the client, but then also understanding that the world of the client has to be separate from our personal world, and we have to keep those ethical boundaries when it comes to dual relationships and other things that we'll be talking about today. So before I move on, are there any questions or comments about these 4 characteristics? And we're going to talk about 4 more. Nope. Okay. So competence, this is a big area for me. I love cultural competence. I love ethical competence. It is something that I really love just talking about. I'm a big learner. I love lifelong learning. I'm a big supporter of this statement that once you feel like you know everything, your career is done. It doesn't matter if you're a doctor. It doesn't matter how many textbooks you've written or how many presentations or how many trainings you've done. Learning and competence has to be an ongoing journey that does not have an end destination. So one of the things we'll talk about as an effective behavioral health professional is that you have to have expertise and mastery of the ethical responsibilities and standards of practice of your field. Understanding that our ethical responsibilities and our standards of practice are going to evolve. You know, the ethical codes that we had 20 years ago may not be fit for the world we live in now as behavioral health professionals. When we think about technology, when we think about new credentials that have been created, when we think about how AI, that's something that's really big now, it's coming in, all of our ethical codes are going to be constantly updating to meet the needs of our field. And it's our responsibility as ethical behavioral health professionals to maintain that competence. Not just read the code and say, I have the code, but actually take training, get continuing education. If you're practicing clinically, to get supervision until you've mastered that technique to where you can say, this is an expertise that I have. The next thing we'll look at is cross-cultural sensitivity, being able to understand and work with clients of diverse backgrounds. And cross-cultural sensitivity is not just about race, or it's not just about gender or religion. It's about understanding the client's worldview and how they identify and how they navigate the world, and to understand it from how the client would like that to come into their services. Whenever I get a new client, I make sure that I assess for how their culture will impact services. Sometimes it creates a barrier. I've worked with some clients where a female therapist or counselor is seen as a position of authority, and that is a barrier for them when it comes to their faith and when it comes to different things that may come up in the treatment and service delivery. So instead of having the client adapt to what we say as an organization or what we say is a policy, we really try to work with the client. There's no textbook in the world that will tell you everything you need to know about your client's culture. And this goes back to that initial point I made about the relationship with the client. The client is going to be the best teacher on their culture, their beliefs, their worldviews, because it's their world, it's their life. So you can read as many textbooks, as many articles, as many trainings on, let's say, how to work with African American and Black American clients, but that doesn't mean that everyone is exactly the same. So really building that relationship with the client will help them teach you how to work with them as it relates to cross-cultural sensitivity. And then we incorporate our ethical codes to really create a robust foundation that allows the client to thrive within the therapeutic services that we are offering them. Next, we need to make sure that we take care of ourselves. As helping professionals, we are givers, and we will give until the last drop. I cannot count how many times I have done supervision for supervisees, for mentees, informal supervision with my colleagues, and just burnout is just pouring out their pores, but they'll just keep doing those notes. They'll keep doing those sessions. They'll work during their lunch break. They're up 2, 3 in the morning, typing things and getting stuff done. So wellness is a characteristic of a behavioral health professional. Just like we have our ethical codes and our obligations to the profession, we have to have our own codes for ourselves, our own limitations that we just do not bend on. If we know we have small children at home and we have a really heavy personal life, we gotta have a cutoff as to when work stops. We have to have a no work on the weekends because this is family time. Like, you have to have a work-life balance, because how can we truly effectively teach these skills to the clients that we serve when we don't practice them ourselves? When we think about coping skills, when we think about things that we're doing to teach our clients about distress tolerance and increasing their ability to just kind of cope and deal with different stressors, if we don't practice them ourselves, it's just lip service. Some of the best things that clients learn from are lived experiences. And I like to give the example of individuals that are like peer recovery specialists, where they may have an addiction and recovery background themselves, and they have certain number of months or years of sobriety, and then they become behavioral health professionals. That journey is very powerful to be shared with clients within limits, because you don't want to over disclose. But if you have never really experienced wellness, if you've never really experienced de-stressing, you've never really experienced self-care, how can we teach that to a client that's experiencing depression or having difficulty managing their psychiatric symptoms? So when we look at that, wellness and self-wellness is one of the characteristics of an effective behavioral health professional. Compassion fatigue is real. Countertransference is real. And usually these things lead to ethical violations. When we are burned out, when we are tired, when we are stressed, we tend to bring the quality of our output down. So an effective behavioral health professional would be one to take care of themselves. And when we cannot take care of ourselves, we recognize that we can't take care of clients. So we take the appropriate leave, we take the appropriate days off, we get the appropriate supervision, we do the appropriate things that we have to do. It's okay to say, I need a vacation. It's okay to say, I need to get counseling myself to deal with this. It's actually a part of our growth. When we recognize that we are ineffective with certain populations because of our own unresolved challenges, that's part of growth. It's not a weakness. It's us recognizing ourselves and doing the work so that way we can be effective later on. So the last point I'll make on this slide is acceptance. When we say that we have a attitude that no matter what our client says within the context of the helping relationship, within certain limits, because we'll talk about the law and mandated reporting today too, the client feels accepted. And we're going to talk about some ways in which we reduce the client's self-esteem later today through our lack of acceptance. We want to make sure we have unconditional positive regard, which is one of the characteristics talked about through Carl Rogers and person-centered, client-centered theory, where he talks about unconditional positive regard, which means as long as it's not anything that requires me to mandate report, it is confidential within this process, and we don't have a shock factor. Our clients should be able to tell us their deepest, darkest secrets with the purpose of working towards trauma, working through trauma, working towards finding themselves without worrying about if we're going to laugh, without worrying about if we're going to gossip with the colleague down the hall, without worrying about if we're going to scrunch our face up or have a reaction or anything like that. So acceptance, I think, is one of the harder skills for us to have, because sometimes the things we are accepting challenge our own values and challenge our own morality. And this is where that cross-cultural sensitivity comes in. And this is also where that awareness of self comes in. So you want to make sure that your acceptance is accepting who you are, so that way you don't push that onto the client, but then also making sure that your client knows that we are here for their journey. They're not here for ours, and we will accept them no matter what they want to discuss. But there are some limits to confidentiality. So I'll talk about that a little bit in the next couple of slides. So before I move to the next slide, are there any questions or comments about these 4 areas of an effective behavioral health professional?
Dr. Winfield, we have a lot of participants engaging in the content from this slide, particularly around the area of competence and cultural competence. Chandra chimes in and says, absolutely agreed. If you begin the relationship correctly, it's easier to maintain and it becomes a part of who you are as a professional. And in light of cross-cultural sensitivity, Martha chimed in that it's also important to be aware of other cultures like Afro-Latino cultures, as opposed to just African-American or Latino, because sometimes those ethnicities intersect, right? Tamika brought up the important point of wellness, how important it is to turn your work phone off promptly at 5 p.m. every day. And otherwise, you never be off of work, right? And then Martha made sure to also share the importance of setting boundaries, because in doing that, we're encouraging our clients and individuals to themselves become problem solvers and enhance their own thinking skills. And Tamika definitely agreed with that statement, saying absolutely, thinking for themselves is a skill they often lack, unfortunately. So thank you all for chiming in the chat. Please continue to do that.
Thank you. So I usually get a lot of feedback on this slide, especially when we talk about wellness, because we've all taken courses in like how to work with the clients and all different types of techniques and stuff. But when it comes to ourselves, we do a lot of self-reflection. And we really start saying, like, I'm pouring so much into our clients. What am I pouring into me? And I think that is one of the flaws we have as a behavioral health professional that we need to recognize. We are true givers and we are the masters of givers, but we got to remember to save a little bit for ourselves. You know, you can't pour from an empty pot. I'm a real believer in trying out different wellness techniques. So when I'm suggesting them to clients, I can speak from a place of I've tried it and this was my experience. For an example, a lot of women I work with now that are dealing with different relationship stuff, and they're working moms and all types of stuff. I'm saying, you know, instead of just read this book on self-compassion, let's try an audio book on it, you know, and I'll even talk about how like the voice of the narrator, how good it was and whether or not they would receive it. So it's important to try out different wellness things for ourselves. So that way it's not just something we Google, but something that we feel would be beneficial to our clients and that we can speak about if our clients have questions about. So it's good for us, but then it's also good when we think about moving our clients along as well. All right, so now let's talk about ethical responsibility. I'm going to be moving stuff around on my screen. So if I get a little quiet, that's why. I can see this whole thing. So it's not just the ethical responsibility of the behavioral health professional, because we'll talk about that a lot today. It's also organizational ethics, because you can be the most ethical professional in the world. If you are in an unethical agency, you're going to constantly hit burnout, stress, anxiety. You're probably going to get a lot of turnover in your employment because the organization itself and the structure and the culture is just not conducive to ethical care. So those are two different things: organizational ethics and then the ethical responsibility of the professional. So I want to take a little bit of time and talk about organizational ethics and what that actually means. So this is the values, principles, and standards that guide the individual and group behavior. So it's not just you as a professional practicing, it's your colleagues, it's your team, it's your unit, you know, it's however your agency is structured, it's those subsystems that are going to govern the behavior of everyone. You know, do we have a culture within our organization where we can report ethical concerns to different individuals and they receive it? Or is there retaliation? Because if there's a fear of retaliation, there could be a culture of silencing unethical conduct or silencing it from certain people. And all it takes is one person to go against that culture to really blow up a whole system and really evaluate unethical agencies, unethical professionals, and really kind of look at how we are servicing clients. So when we look at organizational ethics, all organizations that are behavioral health focused, humanistic, providing that person-centered care, they shouldn't just be avoiding illegal practice, but it should be within the moral compass of the agency to do what's best for society through ethical service with their clients. Now, I say that really broad because every agency provides different services. Some may do like community-based, some may do strictly outpatient, some may do all types, residential, different services. But if we are aspiring as an organization to make sure that we are providing ethical service to our clients. And it starts with our investment in our practitioners. It shouldn't just be the professional's responsibility to learn about ethics. Yes, we get it in our courses and everybody takes a course in ethics. But when we think about the company as a whole, are we educating and doing provider education within our agency? Are we doing in-service training on common ethical dilemmas that may come up within our specific agency? Are we providing continuing education? Are we providing support for training outside of the agency? You know, are we investing in wellness and doing different events so that where there is a team interprofessional culture within our actual organization? Is there a tried and true mechanism that aligns with the field as a whole as to how we address ethical dilemmas? Do we have electronic health records that are kept in a way to where if someone resigned today, someone else can pick up that case and know exactly what went on with that client without any gaps, and the client feels as if their services are continuous? I'm really big on clients being tied to an agency and not one specific provider, because of course we all grow and we pursue different opportunities. But I believe an organization that has ethics built within is going to have ethics in every part of it: our documentation, our service delivery, our relationship building, our communication, how we train and how we support, how we mentor junior colleagues. All of that will be in there. So it doesn't matter if I go on vacation for a week, my client will still get ethical care because they trust the entire agency to be able to be consistent in how they're being treated and how they're being handled and how their services are being delivered. So emphasis on organizational integrity. The integrity of the organization is going to determine the integrity of the practitioners. You know, and no one wants to work for an agency that has a bad reputation for, let's say, not getting paid on time, or, you know, fraud billing, or servicing clients, but they're not really servicing them, or dual relationships with our clients. No ethical professional wants to work for that type of agency. So what happens is we'll get a culture of professionals who don't care about those ethics. And then now we have an organization that is operating unethically. And what will happen is that none of the clients will self-actualize. None of them will move forward towards discharge because they're codependent, or their progress is being hindered due to the lack of ethical service delivery. So the integrity of an organization is based on the culture, it's based on the systems. And while we can't change an organization as a whole, we all have an ethical obligation to report, to ensure that we're doing the mandated reporting, to ensure that the individuals on our caseload are receiving ethical care. And if we feel as if they're not, we have an ethical and legal obligation to report and self-advocate for our clients. So the next thing we'll talk about are, oh, you're welcome. The next thing we'll talk about is ethical codes for the behavioral health professional. So these are completely separate from organizational ethics, and there are mechanisms in place to report agencies. So yes, we have our credentialing boards, we have our licensure boards. Like here in Virginia, we have like the Virginia Board of Counseling, the Virginia Certification Board, the Virginia Department of Health Professions, and they have like a plethora of licenses. I won't go through all of them. But then we also have ethical codes that are specific to our discipline, whether we are credentialed or not. So we have the American Counseling Association, which obviously is going to govern ethical codes for counselors. We have APA, which is the American Psychological Association. So you're going to get your psychiatrists, psychologists falling underneath that umbrella. Your National Association for Social Work, National Organization for Human Services is for like your human service degreed individuals, and then American Association for Marriage and Family. There were a lot more, but I didn't want the slide to have like teeny tiny print by putting them all under there. But it's important, whether you're credentialed or not, to understand the ethical codes of your profession. So I discuss this a lot with my bachelor degree students before they graduate, because a lot of them feel like they can't be held accountable until they're credentialed. So yes, you can't be sanctioned and all kinds of sort of stuff until you're credentialed, but you're still held to the standards of the profession once you get a degree and training in that discipline. And these can overlap. And this is where ethical decision-making comes in. So for an example, my bachelor's degree is in sociology, my master's is in counseling, my doctorate is in psychology, and then I have 9 licenses, and most of them are substance abuse, but I also have clinical supervision, play therapy, human services, rehab provider, there's a bunch of them. So when we look at all of that, I probably have like 11 or 12 different ethical codes that I'm held responsible for. Even if I'm not credentialed in that area, if I do unethical conduct or I mistreat a client, there's some code that's violated, even if it's not addressed, let's say specifically in the counseling one. I may get hit in one of my addiction ethical codes. So it's very important when you look at your identity as a practitioner, that it's not just what am I credentialed in, it's also your degree as well. It's also the agency you work for. So if you work for a addiction servicing agency, you're bound by the codes for addictions because that's the agency you work at. So our ethical codes, yes, they govern us, but they're also tied to our organization. And it's very important for us as behavioral health professionals to get a copy of all of our codes, because sometimes they do overlap and sometimes they conflict with each other. And it's important to go with the code that is the most strict versus going with the lesser one because it's kind of like in our favor. So before I go to the next slide, I want to ask, are there any questions or comments about organizational ethics or our ethical codes as a behavioral health professional?
I think you saw Hank's comment, Dr. Winfield.
Yeah.
Definitely thank you for mentioning this, especially regarding organizational integrity.
Mm-hmm. Yeah. Yeah. All
Oh.
right.
Oh.
Is someone saying something? Hank, were you saying
Yeah,
something?
I was going to say, I do have a question, but I don't know if this is the right time for it. In the presentation, will there be time for kind of more of like a nuts and bolts of ethical organizational integrity and remediation?
As far as what? What do you mean?
I guess I'll just go with my question. So I work as a manager in an outpatient clinic. Part of my responsibilities include when staff leave the agency, or if there are, ethical conflicts within the relationship, either on the client side or on the counselor side, I usually take the case, and I kind of have to rehabilitate that relationship. I don't know if I was looking for like kind of how that would work, but this might not be appropriate time for this part.
We could talk about it right now.
Okay.
Because I don't want you to lose your train of thought. So let me give you an example of what I think you're saying, and you can let me know if this kind of hits the ballpark. So let's say you have a professional that has discharged from your agency, and you're keeping the client within the agency, and now you have to try to like bring the client up to par as to what ethical service would be based off of like the new professional that's servicing them. Is that kind of like what you're referring to?
Right. So either like small things have either not been a consistent thing in the relationship, or, the client has violated the counselor's rights in the relationship.
Okay, so this will be a good time to discuss that. So I would say depends on where the ethics are leaning against. So let's say it's on the client side where they were working with a professional that probably had good intentions, but went too far into boundary crossing, and now the client is kind of like expecting things that are not conducive with the typical client relationship. Have you experienced some of that?
Yes.
Okay, so in that situation, obviously the client will be staying in services, educating the client, because it all starts with client education on what is typical policy. I wouldn't get into like the name blaming or anything like that, or bashing or anything, but get the client's perspective of what they are expecting from the agency, and really reiterating what the boundaries are within the agency and what we can do. Now, those things that other helping professional that's no longer with the agency was doing, it's still a need for the client. So in my situations, as a supervisor and a manager dealing with that, what I do is we'll refer the client out to other resources to get those needs met that were being addressed by that person who went beyond the limits of the agency. So the client's not going without, but they're operating within we're supposed to do, but that need that they had is no longer just kind of floating, not being addressed. So for an example, if the client had issues with transportation. I'll see that a lot where the professional would transport the client to, and I'm thinking about community-based work like mental health skill building and stuff. They would transport the client to things that were not within the scope of services. The client still has that need for that. So maybe providing training or education to the client on how to get that need met outside of our agency will be a good example. Now, if it's not on the client's end, and let's say we just genuinely have an unethical practitioner that maybe had a dual relationship, maybe is, terminated due to boundaries and poor ethics. Yes, we would keep the client and still do that education and really try to get them up to par of what we can do, but we do have an ethical obligation to report. I know now with the Virginia Department of Counseling, we are policing and really, not really policing, but kind of monitoring all levels of practitioners, whereas before it was just master level and above because of like the licensure. But now we're seeing a lot more bachelor level credentials being monitored through actual formal entities and reporting those professionals if they're not doing what they're supposed to be doing, because what you don't want is for them to agency hop, where they leave one agency due to misconduct or poor ethics, and then they end up going to another agency with that same behavior and kind of create a paper trail of clients that are codependent and not really getting the ethical services that they should get. Did I answer your questions, or did you have more questions based off of my response?
I probably will have more questions as we keep going, but I think for now that's good.
Okay.
Thank you.
Okay. And if you have any more, just chime right on in. All right, so before we move on, are there any other questions or comments? Nope, okay. So I know I've been talking about ethics, but we can't really get into ethics without really like dissecting it. So I love this slide because it creates a lot of talk. So there's a huge difference between morality, ethics, and what's legal. And a lot of times we think about ethics, we think about it in like a broad term, and that is all this, big encompassing bubble of just do what's right. But there's morality and then there's legal that kind of challenge, trump, and overlap with ethics. So it's important that we understand all three. So morality, this has to do with our culture and our socialization, which is why doing our own self-awareness is super important. There are ethical codes that challenge our morality, and usually it's dual relationships. There are some things morally that practitioners will do because they just feel it's the right thing to do. For an example, if a client doesn't have any food and they haven't eaten, give them $20 out of your pocket. Morally, it feels like the right thing to do, but ethically, we can't do that. So it's important to understand the lines between what's moral and what's ethical, and really separate, because our morality can create ethical violations. So it's what we feel is right. It's the right thing to do. It's often tied to our religion or our spirituality or our culture and our norms and our families. What we were taught is the best thing to do and how we govern ourselves as human beings. This is where morality comes in. So certain things, such as, being responsible for your neighbors and no talking when adults are on the phone or something like that. Those are moral sort of things. If you see someone in need, you help them out. Yes, it's moral, it's a great thing to do, but as a human service professional, as a behavioral health professional, we may not always be able to act morally. Now, we're not acting immorally either, but we cannot always allow our morals to guide our ethical decisions. So when we do not do what we feel is morally right, the only thing we usually get is guilt. We may feel bad about it or feel like we should have done a little bit more, or we could have done more, but we didn't because of our ethical limitations. So that guilt comes from that feeling bad, and you want to be mindful and really check those feelings, because if they, kind of brew too much, it can lead to ethical misconduct later on. So what's ethical? These are things that are actually in our ethical codes. These codes are, again, they're fluid. They evolve with society. So the codes we have 5-10 years ago, we probably have more. Probably almost every profession now has a technology code up there now after COVID and distance learning and so many technology driven things. Every code pretty much almost has something about technology. Our ethical codes are developed for our specific profession, but it's important to remember that if you have an eclectic identity, like myself, I have my degrees are all in different disciplines. You can't just be like, I only follow ACA codes. You have to make sure that you follow all the codes that are for your identity as a professional. You are required to adhere to these codes in order to maintain your professional status. There is no credential or license that is recognized by the other professions that does not have an ethical code. That is one of the things that are required in order for a credential to be recognized in the behavioral health field, is that it has to have an ethical code. There has to be some rules. There has to be something that everybody who has this credential or this license or this certification holds themselves accountable to. That is required for it. So let me move this little chat thing because it's blocking the bottom of my slide here. So when we violate our ethical codes, usually there is some type of remediation, complaint process, some type of review process, because you don't just get a complaint and then boom, you have an ethical violation. There's usually some type of opportunity where you can defend yourself, you get to hear what the allegation is, you get to kind of speak up for yourself from there. And any violations that are made usually result in a sanction, which can be, training, it can be financial fines, it can be suspending of a credential, it can be revocation. There's a lot of different lists of things that can happen if you are found liable and found in violation of an ethical code. I do love that with the progression of our field and the acceptance of substance use disorders as being on the same level as mental health and other mental challenges and other things that are recognized in the DSM-5, that we're not always resorting to revocation. There are opportunities for behavioral health professionals to do self-care, wellness, and be able to get back into good standing. So I do like that our ethical boards are adopting that philosophy of making sure that we are not holding the line so strong in our field that we end up losing really good practitioners because they just had moments where they really need to kind of pour into themselves. So when we look at ethical, we're usually just dealing with our ethical boards when it comes to violations, sanctions, and all types of stuff. Whereas morality is just guilt, shame, emotions, cultural things, but it doesn't really pour into ethics. The last thing we'll talk about is legal. What's legal is going to trump ethics and morality. We do not want to break the law. What is legal is governed by our government. This is where courts come involved. This is where jail time becomes involved. This is the law of the land. Now, there are some ethical and moral things that would be considered illegal, such as like having sex with a client, especially if that client's a minor. Morally, we know it's wrong. Ethically, it's in our codes, and legally, we can go to jail for that as well. Violations of the law are criminal. They are criminal. So you do not want to violate the law and say, morally this doesn't feel right, because you will probably go to jail and be fined and all kinds of sort of stuff. When we're thinking about legal, you want to be mindful that the courts make these decisions about consequences. When we're dealing with ethical boards, they're usually board members that are also behavioral health professionals. So let's say the National Association of Social Work, whoever reviews complaints against ethical violations are going to identify as social workers. But with the legal, you're dealing with the court proceedings. So it's an advantage and then it's a disadvantage. The disadvantage of dealing with the legal is that they don't always have the training that we have as behavioral health professionals. Whereas in the ethical side of it, we're dealing with like I don't want to say jury of our peers, but we kind of sort of are. So we approach it from the mindset of a behavioral health professional. With legal, we're dealing with someone who has strictly a law background, black and white thinking, which is great because some things, let's say physical harm to a client, like we assault a client or something, we can make sure that those individuals are not able to, move forward without getting the legal consequences that they need to get for things like that. The challenge to that is that humanistic training side, that empathy side, it's not always there. It really depends on who's actually hearing the case. So that's my spiel on the differences between these three. I do want to open it now to the floor on any questions or comments about the differences between morality, ethics, and legal.
I know Martha said in the chat, and this was kind of going back to the ethical piece. In this case, ethical will be providing resources to obtain food.
It just, yes, resources, but you don't want to like give them food. And it really depends on the agency. So let's say if you were at the food bank, ethically, it would be appropriate because that's the services your agency provides. And this kind of goes back to the previous slide when we were thinking about like organizational culture. If my agency provides food and housing and clothing support, if a client comes to me for food, housing, or clothing support, then it would be ethical to provide those services. But let's say my agency is strictly outpatient, we only do individual, family, or group counseling. I wouldn't give my client my lunch because now we're kind of crossing those boundaries there. But I would recognize that the client has that need and refer them to that agency that provides, the food, clothing, or housing support, and then get a release form, which is something we'll talk about later. And then now we can do interprofessional collaboration because I'm pretty sure that's not the only client that could benefit from that resource.
Thank you. And then Hank did say that I think this chart helps me conceptualize my question a bit more. Most of my adopted caseloads are coming from clinicians who are acting in a moral context, helping the client understand and navigate the changes I'm making in the relationship to stay in the ethical domain is usually where the problems arise.
Yes. So I'm glad. I love this slide. It's one of the best slides I've ever created because it really gets the wheels turning and it helps me with supervising. It helps me with really understanding the practitioner's viewpoint. And when we look at morals, if they are having a moral compass that is overriding their ethical compass, this is a matter of supervision. It's a matter of countertransference. There's usually an underlying, I don't want to call it like a superhero complex, but that's the best way to conceptualize it, to where individuals think they're operating ethically, but then they are really acting morally. And this becomes an issue of training. It becomes an issue of supervision. And also, last resort, that may not be the population they're suited to work with because they haven't done the proper care for themselves to address unresolved issues that are now spilling in their service delivery. So that's usually where you're seeing the moral and the ethics. When we think about empathy, and this is one of the first slides I did, you cannot act as if you are the client. That's when it turns into sympathy. Empathy is the ability to understand the needs of the client, but you don't want to act as if you are the client. And this was something Carl Rogers talks about. When empathy turns into an ethical violation, it's because we're acting as if we are the client. We're making decisions as to what we would have wanted if we were in that client's situation. And that's that fine line where too much empathy can turn into an ethical violation. So I love to show this slide to people in leadership because it helps really communicate effectively with individuals that we're trying to mentor, we're trying to develop, and we're trying to get them to think ethically. We have to look at the differences and where that fine line is between morality and ethics. And once we pinpoint it, we can do professional development, we can do remediation, we can do those things to really develop that professional, because a lot of times when they're doing things that are moral, they're not doing it with the intention of harming the client. It's just that they really can't separate the two. And that's an area of professional development. And it's a really good, little click that they probably have some unresolved things, and we need to evaluate whether or not this population is best suited to be treated by that professional at this point in their career.
And Mecca also added to this some insights saying that ethical is about connecting clients to resources and teaching them how to access the resources. Otherwise, it's poor boundaries.
Yes. And it becomes enmeshment, it becomes codependency, which are hard things to break with our clients. And we're going to talk about the client practitioner relationship as well today. And when the client is really enmeshed, they get angry when that professional leaves that organization, or they go on vacation, or that professional is disciplined for misconduct. The client personalizes it. And that's a really good telltale sign of when that line was kind of crossed, because the client should be connected to the agency. They shouldn't be so connected to that professional that they are absorbing that professional's experiences. And it's a really kind of like symbiotic relationship, but it's not healthy because the client doesn't learn to function effectively and independently in the community. And that is the goal of all of our services, no matter what we provide. The end result is that this client will discharge and be independent and functioning in the community to the best of their ability, because that's subjective, but that creates space for another client to take that role. We shouldn't just have the same client forever, depending on what the service is that we're providing. There should be space for clients to move along and create space for other clients that could benefit from that service. But when they're enmeshed, when they are codependent, it makes it really hard for us to move them along to be independent. So I see the chat is going up. Are there any other questions as I'm talking or comments?
And although Hank commented about the boundaries, saying that in his experience, it usually starts from a place of not knowing where those boundaries are. And by the time he sees them, I get them on my caseload and it's almost too late. But Chandra does ask a question stating that, asking, do you feel sometimes if the client is too codependent or too many boundaries are crossed, is it sometimes best to refer them, the client, to another agency of similar resources in order to reset?
It depends. Overall, yes. But that's if the entire organizational culture is too enmeshed. Ideally, you don't want it to be punitive. And if a client has been working with the agency, let's say 4 or 5 years or something like that, you don't want to say, well, you're too far gone and now we're kicking you out. Because that can end up causing them not to connect with the new agency. That's not really considering the client's investment into the services. It takes a long time for our most vulnerable clients to open up to new practitioners, which is why we have continuity of care, which is why we have that term soft handoff and stuff like that. So you don't want it to be punitive. Ideally, it would be best for them to work with a new professional within the agency. That would be like a first level, let's deal with the issue, which is you being, to enmesh with this professional, but you're staying in-house, and it helps the client transition because their services are not too disrupted. But if they're receiving a service from a professional that's not there and the agency doesn't provide that service, we have to have that conversation with the client, not throwing the professional under the bus, but acknowledge where we dropped the ball as an agency and provide the client the best way to receive that services somewhere else. So it really depends. There are some times where the client will choose to go somewhere else because the practitioner that they wanted to work with is no longer available or no longer within the agency. If that is the case, we 100% support them with linking to another agency, make sure the records are transferred properly, hold the case open for an agreeable amount of time to make sure the client successfully linked. Like, we still do our due diligence. The only time I would see a client really transfer agencies is if they've hit what we call maximum benefit. which means like they're just truly not benefiting. And even then, we wouldn't just kick them out. They have to be linked to an appropriate resource, or they have what we talk about autonomy. I'll talk about that today, where they refuse to work with that other agency, which is their choice as well. And if that is the case, the client chooses not to go to another agency, chooses not to work with us, we can successfully, discharge them properly due to maximum benefit, but we make sure they still have that resource where if you ever change your mind, here are places where you can always start up again. I'm a really big believer in clients don't always have to get what they need from us. It may be 2-3 years down the line, 4 or 5 cycles of services before they get it and start moving along. Our job is to make sure that the door is always open to services, that we're always giving them that humanistic, person-centered care to where they don't feel like we're judging them or kicking them out or pulling the rug from underneath them, and that they know that if you ever change your mind, you can always come back.
Yeah. And Karen offered some insight by saying it can be so helpful to frame boundaries in the form of out of respect to you, and you deserve the appropriate support in this healthy way. It can help the client begin to see boundaries as necessary without throwing the previous provider under the bus as well.
Yes, because we want to be mindful of that client's perception of that previous provider. And we also want to be respectful of their rights as an employee. You don't want to discuss things that are done within an agency with a client, because then are we that much better than that professional at that point? So it's a really fine line with communication on how we ethically service that client without throwing that provider under the bus, but also still respecting their privacy as a former employee. But if there are legitimate ethical violations, that shouldn't be the professional just left the agency and then we work with the client. We have a due diligence to do ethical reporting if we have legitimate concerns or even suspicions of concerns of an unethical provider.
Mm-hmm.
Are there any other questions before I move to the next slide? Nope. Okay. All right, so they can overlap, and this is kind of like what we were just talking about a little bit. What you find to be immoral may not be embedded in any ethical or legal code. We may feel it's wrong to do this, or we feel like if the client just got one more chance, then X, Y, and Z wouldn't happen. But you want to be mindful that you are an ethical practitioner first. You have to be aware of your morality and separate it. This is why supervision is so important. Myself, I've been licensed for years. I have 9 licenses. I still do informal supervision because I'm in clinical practice. And I understand that sometimes it pulls in our heartstrings when we're dealing with certain challenges with the client, but it's important to bounce that off of colleagues whose expertise we respect, who are not connected to the case, because they can give us that objective second set of eyes to really kind of help us hold the line, so to speak. So there are some behaviors that are deemed unethical in our professional code, and they may be behaviors we never considered to be either immoral or illegal. This is usually like with gift giving and stuff like that. It is unethical. We shouldn't just have clients work on our houses or buy things off of us, or we buy things off of our clients. But immorally, we could see it as like, hey, I'm supporting my client's business. It may not be illegal to patronize a client's business, but it is unethical because it creates a power dynamic. It creates a dual relationship. So it's important that we don't just look at our codes. It's like clear black and white. And is it illegal? Is it not? It's important to look and consider that they do overlap. Now, there are some behaviors that are strictly prohibited across the board that may be obviously immoral, to us. For an example, physical harm to clients, that's pretty much across the board. Sexual relationships with clients, depending on the nature of the relationship and things like that, that is across the board as well. So there are some things that we don't even want to consider that are across the board, are no across all professions. So before I move to the next slide, are there any questions or comments on this one? So let's talk about ethics and the law. So laws are society's minimum requirements. The laws are not all set in stone. They evolve based off of society. We get laws based off of somebody doing something and society doesn't like it, and now we get laws from it. They are enforced by the government and legislative bodies. They are mandatory. They require compliance. So I don't care what your morals or your ethics say. If it is against the law, it is against the law. And you want to make sure that you understand the law when it comes to confidentiality. And that's one of the things we'll be talking about, because even though morally we try to keep, not necessarily secrets, but privacy, ethics is, ethical codes and confidentialities in our ethics, but it's also against the law. And we'll talk about the 42nd CFR. We'll talk about federal legislation as well today. But when we think about the law, be mindful, it is mandatory, which means jail time, loss of your employment, loss of your livelihood. You want to make sure you always adhere to the law. So ethics, these are the standards of conduct or guidelines for members of the profession. They are aspirational. These are things we aspire to do. This is for the greater good of the profession, the greater good of our professional identity as a group there. And it goes beyond what's simply required. These are things that we are all kind of held accountable to. And of course, when we break ethics, we get ethical violations, we get sanctions, we get fines, we get investigated. Just because you get an ethical violation, it does not mean that it automatically goes into a legal thing. Sometimes it can, but it's not an automatic guarantee. Now, if you break the law, sometimes that will, probably a greater chance, it will become an ethical violation there, especially when we think about like barrier crimes. Most of our professions require, not most, all of our professions require us to do background checks, criminal background checks, and they look for certain things, what we call barrier crimes, assault charges, that type of stuff. These are things that are violations of the law. And depending on the nature of it, how old it was, all that types of stuff, it can prevent us from being credentialed or licensed, or it can prevent us from continuing and renewing our license. So laws generally do impact ethics. Ethics do not always guarantee to impact law. So our codes and laws, so there are similarities. And what are some of the similarities between the two? All of our ethical codes and laws are reactive. Every time we get a new ethical code, is usually in response to something that has been a reoccurring pattern in the field that wasn't in our code. And those powers that be that design and implement our codes saw this pattern enough or thought it was significant enough to create a code that now everybody aspires to follow. Our laws are the exact same way. When we think about laws that we've had, 50, 60 years ago, we get new laws all the time. We change our laws if we feel as if they are discriminatory. And those are some of the things we'll talk about tomorrow when we talk about diversity and all kinds of sort of stuff and working with marginalized populations. So our codes and our laws are changed based upon the trends in society, our values as a field, and what has occurred in the past. So they are very two distinct things, but they do kind of develop at the same rate. Something happens, it's a pattern, it's of significance, and as a result, the law of the land or the ethical code of the profession is adapted to respond to that moving forward. Are there any questions on this slide before I go to the next?
Hank just added a comment, yes, like the telehealth provisions for services from DBHDS and DMAS, direct result of reaction to the recent pandemic.
Yes. And we're also seeing in academia as well too, a lot of things are being brought down as far as quality distance education as well. So COVID, it kind of rocked our nation, but really changed how we provide services. I know for myself personally, there was an influx of referrals and client needs as a result of COVID, and obviously telehealth would have been the service delivery platform because, you know, of the distancing and stuff like that. But before that, we didn't really have a lot in all of our codes across the board, but now we're seeing that. So that's a really good example of how things happen. It's significant and our field evolves to respond. All right, so there are some conflicts between the codes and the law. Again, they're two very different things. The powers that be that govern them come from two different backgrounds, and they're just coming from it from two different angles as far as what they're trying to work towards. So considering that, if you are dealing with a legal issue, do not consult with your colleagues. Colleagues can only really give you feedback and guidance on ethical codes because we're all kind of similarly trained. Legal issues to be given to someone with the legal background on the law, which in this case is going to be an attorney. At the end of our presentation today, there's going to be a QR code that is going to give you guys some links to professional liability insurance. So whether you're credentialed or not, I'm a strong believer in getting professional liability insurance for malpractice. Agencies are required to have that, but you as a practitioner, cover yourself. Even if you're a student, cover yourself. Don't wait until you're licensed because you don't want to get caught up in a organizational legal issue and then you are not covered as an attorney, covered by an attorney. You don't want to automatically assume that whoever's representing your agency is going to represent you. So it's kind of like car insurance when we think about professional liability insurance. So let's say you do get a hit and you do get something that says it was valid and you're sanctioned or whatever. Your professional liability insurance usually has financial limits on it. And let's say you are fined a certain amount, it comes out of your professional liability insurance, kind of like if you have an at-fault car accident where you don't pay out of your pocket, like Geico, whoever would pay on your behalf. That's how the professional liability insurance works. So it's a way to protect your assets. It does allow you to get legal representation, depending on which one you have. There's free consultations and stuff like that. Depending on which policy you have, I know the one that I recommend to my students, it's like $42 a year. And it's a really good investment just to give you that peace of mind if you're dealing with legal stuff to kind of make sure you kind of cover yourself from there. So when you're choosing between the law and ethics, follow the law. Follow the law. You want to make sure that you take the least harmful course, whether it violates law or ethics. Take the least harmful route. When in doubt, consult with an attorney, not your colleagues, because again, we are not educated 100% in the law. You know, we're behavioral health professionals. An attorney is the one that's going to be able to give you that best guidance there. When you're kind of juggling between what's in the best interest of the community versus the individual, and this usually comes up when we're trying to do like TDOs, whether or not a client is homicidal or suicidal, do we do no duty to warn? This is where the laws and the ethics kind of come in play there. So if you're dealing with a crisis, you're dealing with a duty to warn, you're dealing with something where there's a harm to the community, you want to do what's in the best interest of the community. Does it fracture the client relationship? Yes, because they can tell us things and we have to mandated report, we have to TDO, we have to do hospitalizations, especially if they're not agreeable to that. Oh, we are not their best friend after that. But it's important to protect the community. It's also important to recognize the relationship we have with the client. And after we have followed the law and after we have secured the community safety, we follow back up with that client and make sure we try to repair that relationship. Do clients get upset with us? Yes. But if we have that foundational relationship and let them know this had to be done to protect you from yourself or protect you from the community or protect the community from you, or anything like that, you want to make sure that you are not too connected to with your client to where they believe their secrets or they believe that we're friends, because at the end of the day, you have to do what's ethically appropriate, even if your client doesn't agree. So the behavioral health professional, we are vulnerable. It's a very vulnerable field. Our field changes daily. It changes all the time, and that increases vulnerability because you never really can know everything that needs to be known. We have to engage in ongoing personal reflection, clinical supervision. Yes, it's required in some agencies, and if you're unlicensed and stuff like that. But even once you've surpassed that point in your career, you should be engaging in clinical supervision and development. You also should be engaging in consultation. The two of these things, consultation and clinical supervision, helps keep our ethical eye open, helps keep our ethical eye sharp. Because when you have another set of eyes, not necessarily disclosing all your client information, but just on how your decision making is evolving and how you're conducting yourself as a practitioner, it helps you kind of have that check and balances, so you're not kind of operating as like a lone ranger, so to speak. A quality relationship with your clients is also one of the best ways that I recommend to avoid lawsuits. And this is usually when the client is suing us. When you have a really good quality relationship with your client, there should be space for them to bring you transgressions or grievances or complaints with the eye of, I would like to resolve these. Normally, when we get to the point where we're suing and doing lawsuits, or the clients become violent towards us, is they feel unheard. They feel as if their thoughts, their viewpoints, their opinions are not valid or not supported or not being heard. Even if we don't agree, we should have a quality relationship where the client feels comfortable giving us feedback on the services that they are giving or being received, and also the quality of relationship that they're engaging with their agency. So before I go to the next slide, are there any questions or comments on this one? Nope. Okay. So let's talk about now 4 core values in ethical practice and care. So we talk about autonomy. This is where we respect the client's rights and dignity. They have rights to make their own decision. We recognize that clients have their own strengths. We want to build on existing strengths. Most assessments now towards the end, they'll have a little section that are like strengths, needs of the client, resources they may need or something like that. I love to do that section at the end of my assessments, because when you're assessing a client, a lot of times you're going into things that are challenges for them or things they have not really mastered, and that can create a tone of like negativity depending on how we're asking the questions. But that last little thing at the end, what are your hobbies, your interests, what are some strengths you have, what are some things you're good at, it kind of lets the client know we're not just interested in how we can help you. We're also interested in things that you've mastered and things that you feel proud of, and that kind of builds that relationship. So I like having that question at the end, because it's the last thought that the client has of us, and it kind of really sets the foundation for a positive relationship to manifest. You want to be mindful that the client has the right to informed consent, which means we want to explain things to them in a language and using wording that they can understand, and that way they can make their own decision. Most importantly, we want to be mindful of the client's right to privacy and confidentiality. Those are 2 different things, and we'll talk about those today. And we want to make sure the client understands that there is limits to what we can disclose and what we can keep confidential within the service delivery. And then they can make a decision as to what they want to disclose, understanding those limits. So the next value we'll look at is benefits, which is basically, how does the client benefit from this? And this is where that discharging due to maximum benefit, if the client's not benefiting from the agency, this is where that comes in, one of our values. We want to always promote good. We want the client to always benefit from the services that we are getting. We want to protect the client from harm, or the public from harm from the client. You don't want to keep a client in services just because they meet criteria. If they're truly not benefiting, we have the due diligence requirement to sit down with this client and really look at that progress that they're making and have the client's voice involved in this process. Is this the best agency for you, considering the progress or the lack of progress and the way we're working towards goals that are moving or not? You don't want to always assume that it's the client's fault why progress isn't made. We really also want to look at our service plans, because sometimes the goals we have are not appropriate for the client's level of need and where they are in their healing process. Sometimes we have to start with lower level goals and work our way up to those larger goals versus just hitting them round one and the client keeps falling short. So when we look at what's benefiting the client, we're looking at how does this benefit the client? And if it's not, how can we try to help it and make it structured so that way the client can benefit from there? Next thing we'll look at is non-maleficence, which is basically doing harm to the client. No harm should be done to the client. We should not be exploiting them. We should not be having them work for us or doing services for the client beyond the scope of our job description, sexual relationships with clients, dual relationships with clients. We should not be putting family members, friends in services. Like, we really don't want to do any harm with the clients, because that creates a power dynamic to where the client's voice is silenced, or the client feels as if they get special privileges and opportunities that are not given to other clients that don't have that special relationship. And then next, we're going to be looking at justice, and this kind of relates to countertransference, our cross-cultural sensitivity, knowledge of our own culture, and making sure that we're providing non-discriminatory services to the client. And we'll talk about more on this particular topic in our discussion tomorrow. So before I move to the next slide, are there any questions or comments on this particular slide on our core values? Nope. Okay. Understanding the role of ethical codes. I love ethical codes because they are guidelines to help us kind of really get a vision as to how we are going to provide services. But the values which inform the behavioral health practice, teaching, supervision, and research, that is what our ethical codes are. It's like we have our morality based off of us as an individual, but our ethical codes is kind of like our morality as a professional. You have to be able to operate within the moral ethical compass of the field. It may conflict with what we think personally, but we want to make sure we uphold that uniform thought process for everyone. And that makes it easier. Looking at the example Hank gave, if we're all operating with the same ethical mindset, then it doesn't matter if the client has had 5 different practitioners within that agency, they would get the same quality care because we're all aspiring for the same thing. Our ethical codes are not set in stone. They evolve over time, which is really great because, again, we don't want codes that are only appropriate for 30 years ago. We want codes that continue to evolve and continue to inform our field, which is why education and ethical practice is really important to have at least yearly. I like to do at least every 3 to 6 months, depending on what new thing is out there, but you want to make sure that you constantly educate yourself on what's ethically appropriate. And the more you develop in yourself as far as skills and techniques, you're going to have more ethical questions and you're going to continue to get supervision and mentorship. Again, you want to share concerns for the welfare of those they serve. This is where that advocacy comes in. You want to advocate for your clients, but you don't want to over advocate. Part of advocacy is education. You want to make sure that you're educating the client on how to advocate for themselves and those they are responsible for. Advocacy is a fine line between speaking up for the client and then fostering codependency. You know, when we have some clients that are experiencing challenges with communication, of course, we want to model, you know, how to speak for themselves and bring up certain terms, but advocacy, we want to make sure they're able to do that for themselves. And this goes back to autonomy and educating the client. The more educated they are about their services, their diagnosis, their treatment goals, the more involved in that process, the more they're able to be experts in their own treatment, and as a result, are more likely to self-advocate later on. Our ethical codes are just guidelines. They're just guidelines. We don't want to ignore the law when it comes to ethical codes. They are the standards against which practice decisions and actions can be judged. This is a really important topic because just because you don't know the ethical code does not mean that you're not held accountable for it. I want to make sure we emphasize, again, just because you didn't take the time to learn about this ethical code and these new standards does not mean that you're not held to it. You can't plead ignorance when it comes to ethical complaints or when it comes to ethical standards. It's our obligation as a professional to constantly educate ourselves and hold ourselves and our colleagues accountable. Again, our ethical codes usually have disciplinary and sanctioning things in place, and those are usually outlined in public information so that we are aware of what those processes are. All right, so I now want to open the floor up to any questions or comments that may have come from this slide.
Great. I don't see anything in the chat at the moment, but this might be an important time to take a break.
Okay.
Yeah.
Are we going to 11:45?
Yeah.
Okay. All right. So we
No,
have.
I'm sorry. So 11. I apologize. I misspoke. So at 11:45, we'll take a break.
Yes, at 11:45. Okay. All right, so our ethical codes and professional considerations. Again, it's important to get membership in your professional organization because a lot of times you can get access to free CEUs. You can get emails on different trends in the field and stuff like that. And when you are a member of a professional organization, you have access to conferences and other interprofessional opportunities that really just kind of develop your moral compass as a practitioner and your knowledge of ethical codes, a really good opportunity to network outside of like your immediate agency. And it's just common practice for practitioners to join an organization for their discipline. Across all disciplines, the helping relationship exists for the client's benefit. So you want to be mindful of that. The helping relationship is for the client's benefit. It should never benefit us. And we should always be operating from the lens of having concerns for the client's well-being. Are there any questions on this one? Nope. All right. So now let's talk about the rights of the individuals that are actually receiving services. So I talked about this a little bit when we were talking about autonomy, where the client has the right to participate in planning of their services. This is a really good technique to employ when we are building a relationship with the client. If they are a part of the planning process, when we talk about assessments, when we talk about treatment planning, when we talk about referrals, when we talk about identifying resources, they're more likely to execute the plan. So when we think about, I don't want to say client resistance, but clients maybe not moving forward, we want to make sure that the plan is theirs and is written in a person-centered language. You want to remember the human side of our services. We shouldn't be dictating to the client what we want them to do. They should be involved in that process, and it should be collaborative between us and the client and any other entities that are involved in their service delivery. So the clients have the right to self-determination, and this means educating themselves and receiving education on their diagnosis, treatment options. They're allowed to ask questions. They don't have to agree as soon as we bring it up, giving them opportunities to think about it. When we think about cultural factors, maybe discussing it with their support systems before agreeing to certain treatment options. They also have the right to make mistakes. We don't want them to just be perfect across the board. They also have the right to decide when and for how long they're going to use a service. Just because we feel like they could still use the service, the client may feel like they don't want to do it. There should be no penalty for that. Informed consent. They have the right to consent to or withdraw services. This becomes a little tricky when we talk about the 42nd CFR, so I'll make that the last point on this block here. So some of the things that we are looking at when we talk about informed consent, they need to know about side effects for different treatments and medications, adverse effects, negative consequences if they refuse, negative consequences if they agree, if there's any risk. If they elect not to accept our recommendations, this is when we are having like maybe mandated clients that come from probation, parole, CPS, what are the risks if they choose not to do certain treatment recommendations? Even though we may not have any consequences, there may be some legally, and that's part of that informed consent process for the client to make informed decisions. They also have the right to know what services are being offered, what are the risks and benefits of those services. I like to talk about all the services the agency offers kind of like a menu. Even if the client's not taking every service, they at least know it's there if they do need it. Remember the 40-second CFR for clients that have substance use disorder diagnoses, and this includes minors, because without that substance use diagnosis, HIPAA says pretty much that a client puts not informed consent, puts the release of information in place in writing, and then they can revoke it in writing. That's kind of like our standard. But with the 40-second CFR, clients that are either comorbid, which means they have mental health and substance use, or they just have substance use, they can still put it in place in writing. That has not changed. But when it comes to revoking consent, they can do that verbally, and that is a law. That is a federal law. So you want to remember the 40-second CFR. I don't want to spend too much time on that in this presentation, but it's definitely something to look into if you are working with clients that are comorbid or substance use disorder. Also, if you're working with minor clients and they have a substance use disorder diagnosis, they're automatically treated as adults unless they do not have the cognitive capacity to give consent. So that is something where the law kind of infiltrates our ethics, because our ethics say confidentiality, informed consent, but the law kind of makes it a little bit of a gray area depending on which diagnoses we are treating. So that brings me to confidentiality. It is an ethical principle and a legal right, which means it's in our ethical codes and it is in the law. Written consent is needed to staff cases outside of our agency, which means you need a release form from the client to discuss their information with anyone outside of your agency. You do not need written consent to discuss it within the agency. So like with your direct supervisor, they should be able to review your records and give you supervision. You do want to request a release of information before you even confirm or deny whether or not a client is being serviced by your practice. And this is kind of like phone calls and stuff like that. And ethically and morally and legally, we should not be discussing our cases with our personal network. We should not be saying, I have X, Y, and Z client, this is what they did today, and oh my goodness, this was so funny. That is not something that we would be doing that would be conducive with an ethical behavioral health professional. All right, so for the sake of time, we're going to move to the next slide and make sure that we kind of end on our break slide. All right, so we do have an ethical responsibility to the actual client. And these are things that we want to make sure that we aspire to and we kind of check ourselves on. Within the helping relationship, obviously, it's conversational. We communicate with our clients. We should not be burdening our clients with our own problems. Our clients should not become our professional, where we kind of relate to them on some area of life that they're experiencing. And now all the sessions are dominated with our personal issues. That is a really hard thing for clients to bear, and it kind of really enmeshes the relationship. We don't want clients to meet our own needs. They shouldn't be buying our Girl Scout cookies or insurance from a friend, or if we know a client has a business, ask them to come clean our homes. Like, they should not be meeting our own needs. We should not be insisting our own solutions. We should not be telling the client what to do. I always say, never give advice to your clients. They should be making their own decisions, and we are just guiding them through their solutions that they come up with, or we support them in coming up with. It should never be giving advice or telling them what to do, because that is a hallmark of codependency. Next, you don't want to exploit the client. You don't want to continue to treat the client when they have grown beyond the needs. When it's time to discharge, we discharge. Yes, it pulls in our heartstrings because they've been such a good client and they've done so much work and we've grown with them so much. But when it's time to discharge and move on, we have that ethical responsibility to kind of facilitate that process. Are there any questions on this one before I move to the next one? Oh, okay.
My question was more for
Yes.
Can you hear me?
It's a little low, but go ahead.
I work in the courts, so sometimes service is mandated. So I just wanted to bring that case for the previous slide that you showed. Cases are mandated. How do we go about giving the client the opportunity to decide what kind of treatment they want to go for?
You said, you repeat that one more time because you were very low.
How we give our clients the opportunity to decide what treatment they want to proceed if specifically some things are mandated. Like for
So,
instance, family therapy is mandated, but the client or the parents don't want to engage in family therapy. So how to go about those?
So we want to make sure we separate what the client has the rights to as our client from what is required from the courts, because that's the difference between ethics and the law. Ethics say the client has the right to decline.
Yeah.
The law says if you decline, you're going to go to jail. And this is where that informed consent comes in. And I like to use the example of clients that are on probation and parole, because a lot of times they are mandated into counseling as part of their aftercare plan. You still have the right to decline. Will your PO violate you? Yes. But as far as your services with me, I still have to offer that to you.
Okay.
And if you decline, you decline. We treat it as a regular decline, but you're making an informed decision that those consequences may come from the court. We don't want to take our practitioner mindset and mesh it with the law, because the law is black and white. You know, if you don't do this, then fine. But when it comes to us as a practitioner, you always have the right to decline. Is there consequences? Yes, but it's not from us. It's consequences from the court. And that's you making an informed decision.
Thank you.
You're welcome. All right, so let's look at some ways in which we may mistreat clients. So there are some situations in which clients are mistreated and clients are not given that ethical service delivery. And these are four common, they're not all inclusive, but sometimes the worker just has a really unpleasant demeanor with everyone. They're just in a really hard chapter of their life. And because the client is in that vulnerable space, they're the ones that are in that submissive position. They're really relying on us to support them in whatever it is that they're getting services for. They're usually the first line of target because they're the closest to that professional. The worker tries to control unpredictable behavior with verbal or physical aggression due to lack of training. So sometimes professionals are acting outside of their scope of competence and they're isolated with unpredictable behaviors. And as a result, they respond based off of their morality or what their instincts are instead of what they should ethically do to provide that quality care for clients. Next, we'll look at a need for power. I'm a big supporter of doing our own self-care, our own work, dealing with our own traumas, dealing with our own things that are unresolved. Because if you don't, it may come out in our services, very likely. So for an example, if we have a history of being bullied, if we have a history of our voice not being heard, if we have a history of feeling as if we're demeaned and all sort of things that are negative, and then let's say we get with a client and we are experiencing some serious countertransference where this client may remind us of a bully from middle school. We may exert that need for dominance onto the client in that moment or in that need because they are reminding us of something that is unresolved. So in this situation, we have a need to feel superior and have power over the client. And if we have not done our ethical work and self-care, we're going to act on that. And the last one here, I kind of like to tie this to organizational ethics. This is lack of support. This is like really, really high caseloads. We're working after hours with no supervisor on staff here, no supportive interventions, no space to really do ethical care. And as a result, we tend to kind of do what we feel is best with what we have available. And it develops a us versus the client attitude because we burned out, we're tired, we don't have the organizational support. So each one of these things are problematic for us as a professional, but then also for the organizational ethics as well. We have 2 minutes, so I want to open this up for questions and then we'll jump into our break.
I see that, I believe, Janice, your question, you asked it, but let us know if you want to revisit it. But Hank mentioned we have this a lot at my agency too. We follow ASAM and try to engage clients in whatever level of care they will accept as long as there isn't imminent risk, but looking forward to other thoughts.
Mm-hmm. Yes, and that's the biggest thing. When we respect their autonomy, they may only accept one service, even though we know they need 4 or 5. They may only be ready for that one. So we meet them where they're at, because that one service, if it's done well and that client buy-in is increased, we may be able to get them to jump into 2, 3, and 4 later. So you don't want to feel like you have to get the whole gambit round 1. It's about that relationship, that buy-in, and healing is progressive. We don't have to do it all right when they sign up. It may take some months and maybe even years, depending on the service that we're providing, for them to really move at that pace, but the importance that they're moving along. Any other questions before we go to break?
I don't see any other questions, but just, well, actually, Tamika asked a question, as Chandra confirmed that absolutely the practitioner should practice their own mental wellness, and even a running car gets oil changes and maintenance. But Tamika asked, how would I suggest self-help, possible therapy to my coworkers? Some of them need it.
Okay, so first I would say it's hard for us to get services for ourselves because we run the risk of, I don't want to talk to a colleague, or I don't want my professional reputation to kind of like, I don't want my personal mixed with my professional. So it is hard for us as practitioners to get counseling and other things. I would say to look outside of where you service and where you work to try to get the work that you need. All of us have supervisors. And it's important not to have a supervisor that's just administrative, but one that develops us professionally, and to see what kind of recommendations they may have. Attending conferences is also a really good way to network outside of your local area, to see what other providers are out there and what other resources are out there as well. And then we look at self-care. It's important to recognize that it's important for us to get the work that we do. So we don't want feelings of like, I don't want people to know this, to stop us from getting the services that we need for ourselves, because everybody's going to find out at some point when the small thing that we should have dealt with privately becomes an ethical violation, because those are public knowledge. So it's either deal with it now privately and get the work that you need and kind of network with your mentors and things to get the help that you need so you're effective, or it's going to become something big because we left something that was small untreated and now it is something huge. So I see the chat going up. Are there any other questions? I can't see the comments, but I can see the numbers going up.
We ran right into our break time. And so thank you for that response. It's a lot of confirmations exactly to what you just said. So this is when we're gonna take our break, and then we'll come right back at noon, 15 minutes.
All right, can you all hear me okay?
Yes.
Yes. All right. So we're going to jump right on in. And for the sake of time, let me go back to sharing my slide. I'm going to browse through the comments really quick.
Yeah. Excuse me, Dr. Winfield, I do see
Yes.
that Sandra asked if we could return back to her question, particularly around that dilemma about help-seeking behaviors. She mentioned, I do find that oftentimes it's an issue of confidentiality and trust, and not wanting colleagues to know, and was hoping that we could revisit this part of the conversation after break.
Yes. So let me go to that actual slide. Let me go back. All right. So it was this one here. So yes, and I actually have encountered this as a supervisor, providing supervision, and my directive being that my supervisee or mentee seek professional counseling to deal with internal challenges that are impacting their practice. So yes, we deal with the embarrassment. We don't want to feel vulnerable. We don't want our colleagues to look at us in a certain way. But as I said before the break, unresolved issues in the work that we do, it's going to come out in some way. If it's bothering us enough that it's impacting our work to where our colleagues are noticing something, it's only a matter of time at that point. So we have an ethical obligation to ourselves to, if my colleague comes to me and say, hey, are you doing all right? You seem a little off or anything like that, that should be the first check to say something's not right, where it's now noticeable for people to start bringing it to our attention. We do, and I'll have a slide slide where I'll talk about impaired colleagues. It is part of our ethical obligation to the profession that if we notice an impaired colleague, to give them a nudge. Depending on what we're seeing, there are some things you wouldn't bring to the colleague. It would go straight to leadership or a supervisor or someone in administrative because it is directly harming a client. When we are informing our colleagues and kind of checking in on their impairment, it's usually something that maybe we're seeing, like they're late all the time, or their documentation is not submitted in a timely manner, like things like that. But if we're seeing like they're taking medications from a client, or they're at a client's house at odd hours, or they're not supposed to be, these are things you don't want to give the worker a heads up that you're noticing, because then they could cover it up, they could threaten the client, and then we could be increasing more harm to the client. So going back to Sandra's comment about, there's that level of trust. We don't know every professional. We only know the ones that we interact with, we collaborate with, in our local area, most likely. But we have a due diligence for ourselves. So if we really feel as if we need to get services or we need to do our own self-care, my best recommendation is to go outside of your work network. Even if you have to get an out-of-state provider, even if you have to get one that's a little bit further out, but still in your insurance network, but they're not tied to your agency. That is our responsibility to do self-care. And like I said before, if we don't do it, it's going to come out on its own. It's kind of like a health condition. If we know that we have a health ailment or ache or pain, and we continue to just kind of let it go, at some point it's going to get to a point where our body says, you need to address this, or I'm going to make it known that this is an impairment that you have. Did that answer your question, Sandra? I can't see the chat.
I don't see that she's commented after that. I do
Okay.
have a question, and feel free to chime in, Sandra. Renata asks, how can therapists be embarrassed to seek help? I'm from Brazil, and in there, when I was in college to become a psychologist, it was pretty much mandatory that we seek out our own therapy before we become a therapist.
That's a really good point. And I can see both sides of that. On the graduate level, we usually are mandating counseling as part of being in the seat of a client. Helps you really understand. So it's more like experiential learning. And it also is a gateway for us to really deal with our own challenges before we go into the field. But I commonly see that embarrassment for people that are in national leadership roles in the field, where they're readily recognized and they're known for different things. And then also on the bachelor level, where it's not always required for them to complete their programs to engage in counseling. Those are usually the two areas when they're like really, really well known, known for their craft. It's hard to find work, find services for themselves or family members. And then where they're not required to do it, and they are still kind of developing their ethical identity, that's also where I see the whole embarrassment, because I don't want this person to think something's wrong with me and then they won't supervise me later on. Or I don't want to go to this practice because I may want to use it for a residency later on, even though there's practitioners there that can help me with my personal. So I can see both sides of it, and either argument, it's a matter of self-awareness, self-care, and really kind of reducing our ego, so to speak, and recognizing that everybody needs help. There's no behavioral health professional that is just perfect in every area of their life. That's what helps us develop empathy, and that helps us be relatable to our clients, because we all have something that we have overcome or are still dealing with, and employee assistance as well, like Norma says. So there's different avenues for us to get services discreetly and privately, and we are all bound to confidentiality. So even if we're working with someone that we're familiar with their work, but we just don't know them personally or professionally, that is a really good way for us to get the work that we need. And it's just all about perception. Are you doing it because you're forced to do it? Because then that's where that embarrassment may come in. Or are you doing it because you see that there really is an internal need and you're trying to do something about it?
There's one difference in international schools, like I'm from Colombia and I did my bachelor in psychology in Colombia. It's the same question of the person from Brazil. In these countries, when you go to enroll in a bachelor to do psychology, it's a 5 years programs with a thesis and dissertation. So you and being a psychologist and providing the clinical services is the equivalent of here, a bachelor plus the master. So that's what in our countries, and I don't want to talk for Brazil, but I want to talk for Colombia. We are required when we're in the bachelor to get the services, because when we are done with our career, we're going to provide the service.
Yes. And I think that goes back to the organizational ethics as well, too. Is there EAP, available? Is there a culture of, just looking at our own self-care? Like that goes back to our organizational culture, and then also the culture of climate of behavioral health field where we're at. Is it the norm to get mentorship and things like that? And I think that goes back to the organization setting the standards and the culture of our service provider area, normalizing that culture of, do your own work before you can really help someone do theirs. All right, so for the sake of time, I'm going to move to these last two slides and then get to our part two. So when we look at stealing the client's self-esteem, we already talked about things that we can do as far as our ethical obligation and how those can be violated. But there are certain common practices, unfortunately, in our field that are commonplace that reduces the client's self-esteem. So the first one is being rude or brusque, which is like abrupt, with the client, or demeaning them. Ignoring the client, and it's not always just ignoring like you said something, I didn't respond, but ignoring their requests for services. If they left us a voice message, not responding in a timely manner. If they need documentation sent to, let's say, their PCP for something, we don't respond within a timely manner in accordance with our agency policies. Or if they have a request for an emergency appointment, we just wait till the end of the day or 2-3 days later to get to it. But if it's an emergency appointment, obviously it's an emergency, but those are just different ways that we ignore the client, and it can reduce their self-esteem and cause them to really question the clinical relationship and our genuineness. Refusing to return their calls or acknowledge their concerns, or if our last meeting with them kind of ended pretty intense, not really addressing the elephant in the room and not really taking the time to acknowledge where we've dropped the ball. Sometimes we have what we call empathic failures, where there are moments where we should have shown empathy or we should have shown concern, but we dropped it. We missed it. We just totally missed that moment. And it's not until like after the session or we're talking about it with our supervisors that it's brought to our attention that we should have explored it more or something. But going back to those moments and saying, hey, when you were talking about your work stress, I asked you about your children. And in that moment, you really wanted to focus on your work stress. So I want to acknowledge that I didn't explore that with you, and I want to give you that opportunity now, because in that moment, I could have reduced that issue for the client to just being minute or just small when it was big to the client at that point. So whenever we have those moments where we reduce the client's self-esteem, or we have those empathic failures, or we may have laughed at something that the client may not have felt was funny or anything. These are things that can reduce their self-esteem, and it's our responsibility ethically as an ethical practitioner to address them, to rebuild the relationship, and to really try to move forward from those in a way that the client is satisfied. Otherwise, it can really create like this tension, and the client can start missing sessions. They'll start no-showing. They'll start like pulling back, not disclosing as much. So we really want the client's self-esteem to be in a really good place to where they feel comfortable disclosing, they feel comfortable engaging, they feel comfortable following through with that collaborative process from there. All right, any questions before I move to the next one? Nope. All right, so this will be the last one before we move to part two. Being an ethical practitioner, just to kind of summarize part one, it's important to remain informed. It's an ongoing process. Learning does not stop once we've graduated or once we've got a certificate. You want to always stay up to date on what the requirements are, and not just know what they are, but how they can be incorporated in your day-to-day practice. Reflecting on how the codes impact your decision-making and your practice, and have those conversations, not just in your head, but really bring bring them up in your staff meetings, in your group supervisions, like really make those collaborative discussions on how we can implement these codes and make sure we're adhering to them as an organization. Dialoguing with our colleagues, but understanding when it comes to legal situations, it shouldn't just stay at the collegiate level. It needs to go above, to a legal, to an attorney, if it is something that impacts legal. And then continuing to reflect on our own values and beliefs when we think about cross-cultural sensitivity, when we think about justice, when we think about the difference between morality and ethics, making sure that we're reflecting on our own and it does not get too far into our work to where we're now engaging into unethical practice. All right, so we're now going to switch to part 2, where we're going to actually talk about actual codes themselves and kind of dissect them a little bit. We're not going to go through each code, but we're just going to talk about standards of practice across all disciplines, and then some of the little hairy gray areas that kind of come between ethics and the law. So let's talk about some common standards that are across all of behavioral health disciplines. So this is like all of our codes: confidentiality, privileged communication, informed consent. We are going to dissect that now. Boundaries and dual relationships, duty to warn and do no harm. We're going to talk about the Tarasoff case so just a little bit. Competency, use of technology supported services, and that kind of ties into confidentiality. And then of course, record keeping and documentation. These are just some common things across all of our disciplines. This list is not all inclusive, but these are some of the main ones that we'll kind of hit on within the time window that we have today. So let's talk about the differences between confidentiality, privacy, and privileged communication. And this helps us go back to that original slide where we had morality, ethics, and the law. So confidentiality, we know, is an ethical principle and a legal right. It is the legal duty to protect the client's private communication. So we have 2 main laws that tie to confidentiality, really 3. We have HIPAA, which is behavioral health. We have FERPA, which is like educational records. And then we have the 42nd CFR, which is like a little subset that kind of goes over substance use and mental health records. Across all of them, they talk about confidentiality being maintained. That is a really good requirement for the clinical relationship. If I can't trust what I'm going to say to you remains between you and I, or between your agency and I am not going to share it. I'm not going to share it. So the promise of confidentiality is not absolute. So when we are going over the initial intake and we talk about confidentiality, what goes on in a session stays within the session, that should not be the endpoint. We should say, unless it falls under one of these categories, and provide the client the opportunity to be able to ask questions about each one of those things in which confidentiality may be broken. So when a reasonable practitioner has the duty to protect clients or others from serious or foreseeable harm, confidentiality is in place. Again, it is an ethical principle and a legal right. So if you are under investigation or found to be in violation of these things, it can hit on both areas. The ethical codes, which leads to revocation, suspension, fines, sanctions, all that stuff, and then legal sides of it. If you go on the Board of Counseling or Department of Health Professions website, a lot of our ethical violations from colleagues and practitioners are public information. And when you kind of browse, confidentiality and dual relationships are usually the biggest ones that lead to big fines, sanctions, revocation, suspensions of it. And what I commonly see is like storing of records, disclosing information without release forms, getting a dual relationship with a client, and then that client now has access to other clients' information. Like it can get really muddy, but we want to understand that confidentiality is our ethical and legal duty. It is something that we can get hit on both ends, ethics and in the legal spectrum. So privacy, and this is where some people get confused, is 100% on the client. We cannot be held liable for anything that is private. There's a difference between confidentiality and privacy. So privacy is the client's right to choose what to say to us and when to say it. So I like to give this example. I have 3 dogs. So before I said that to you all, it is considered private, which means you all cannot be violated ethically for my dogs. Let's say I have a dog abuse charge or something. You all didn't even know I had dogs before I said that. So let's say I get caught up with some type of dog neglect case as a client. As my practitioner, you can't be held liable for any of that because there's nowhere in my assessment that I have dogs. I've never talked about dogs. I've never even mentioned it, or you've never even seen a picture. So that is considered private. Anything that I keep private as a client is not something you can be held liable for. So this is where that informed consent comes in, because if you tell me that anything that you say, except for abuse and neglect, I have to, keep it private or keep it confidential. But once you tell me it's a violation, I'm going to report it. I'm making an informed choice not to tell you about my dogs. So that is privacy. You cannot be held liable for anything the client is held private. Now, privacy does have its little gray areas there, and it boils down to documentation. If you did not document that you assessed that area, then that is where the malpractice comes in. Let's say, for an example, I am a client and I am coming in for substance use services and I'm pregnant. I don't disclose that I'm pregnant and I'm using fentanyl, and I start having medical complications, and my unborn child is now harmed as a result. I could easily sue and say, well, you didn't tell me that fentanyl impacted my fetus. You didn't tell me this. And now I'm going to sue you because my child is now, experiencing different medical challenges. And as my practitioner, you didn't tell me about that. This is where your documentation comes in. Because if you document that you asked me about pregnancy, when was my last physical, and if I'm currently, all that stuff, you asked about it, and I said no, that is considered private. It is not until I tell you that it falls into the realm of confidentiality. But if you never documented that you ever asked me, then now that's where the negligence and the malpractice comes in. So this is a little good way that I train my students to get around that. You document, behavioral health practitioner assessed, inquired about pregnancy, client denied that it occurred, and client declined to provide that information. Those two words, denied and declined, cover you in the difference between privacy and confidentiality. Because if you ask me about pregnancy and I say I'm not pregnant, I am denying that, which means you did your due diligence as a practitioner and assessed that area. I lied about it. If I say, I don't want to talk to you about my sexual history, I don't want to talk to you about my pregnancies, I don't want to share that with you. Why are you asking me that? Where's this questions coming from? Then you can say client declined to provide that information. Those two words is where that protection comes from, where I can still come back and have a case, but the chances of it being founded are reduced because you did your due diligence as a practitioner. So again, until I actively tell you as a practitioner, then it is private, and you all cannot be held liable for private information. Once I tell you, now it becomes a part of the clinical record, and now it is bound by ethical and legal regulations at that point. The next thing we'll talk about is privileged communication. This is strictly between the practitioner and the client in legal proceedings. So this prevents certain things from being pulled into legal proceedings. Generally, we would get a release form to release records, but the law can trump privileged communication. So when we're talking about court orders, we're talking about subpoenas, this is where our release forms are kind of trumped by the law. So let's say that we're dealing with a divorce case and it's a custody dispute. And let's say the defendant wants to pull our client's information to say they are unfit parent. Our client can say that's privileged communication. I don't want that pulled into a court proceeding. I am not giving you a release form. We cannot confirm or deny whether or not that person is a client. But if that defendant comes back and gets a subpoena for our records or a signed court order, then that release form is kind of trumped because now the law is pulling that in. Do we discuss that with our client? Yes, but we still comply with that subpoena and that court order. So you want to be sure that you are mindful of the differences between these three, because this is where the ethics and the law kind of compete with each other on how we resolve ethical decision-making when it comes to confidentiality, privacy, and privileged communication. So before I go to the next slide, are there any questions about the differences between confidentiality, privacy, and privileged communication? Nope. Okay. So let's talk about confidentiality a little bit more. So this is the client's right to decide the time and circumstances under which to disclose personal beliefs, behaviors, and opinions. It is a central factor in the trusting relationship. It's just them telling us. Anything we don't know from that moment on forward, like I just said, I had 3 dogs. Now, if I was your client, that's considered confidential information. Before I told you, it was private. So that is the difference between the two. Ethically, information discussed in the helping relationship will not be shared outside of that relationship unless it is clinically appropriate. So let's say we're doing supervision, we're making a referral, and we have a release form on file. So there are some times in which confidentiality would need to be broken in the kind of day-to-day procedures of treatment. And then there are some times where it's mandated, and we're going to talk about that in different slides. So I have a standard from the National Organizations for Human Services that kind of talks about confidentiality in a broad sense, where it says that the human service professional, behavioral health professional protects the client's right to privacy and confidentiality, except under which terms in which there's serious harm to the client or agency or state guidelines dictate otherwise. So you want to make sure that you educate clients on what that means, serious harm to the client or others when agency guidelines. You want to make sure, or state guidelines, you want to make sure you educate the client on what that means so they can make an informed decision on what they want to keep private and what they want to be bound by confidentiality. All right, next we're going to talk about limits of confidentiality. These should be shared at the onset of a professional relationship. I am a strong supporter of giving this to your client in writing. Giving it to your client in writing, because during the intake process, it's just like whoosh, information overload. The client is getting intakes, they're signing forms, they're doing so much stuff, but this should be something they're given in writing so they know what these limits are. They're able to reflect on them. They're able to kind of reference them. And then we can document with the client that we reviewed it during our intake and assessment, but they were also giving a written copy for their personal records, just that extra layer of protection for us. The client has the right to waive privilege and disclose confidential material. Again, this is done in writing. This is done in writing. We don't want them waiving things just like over the phone. Oh, you can call such and such. We shouldn't be doing that. It needs to be done in writing. And also when you do get it in writing, the date and the time and all that stuff needs to be documented. The client should be aware of conditions in which disclosure of information will occur without their consent, because this is usually where our ethical complaints and things like that come in, especially if that disclosure caused some harm to the client, but we were ethically bound to do so. So if they are a danger to themselves or others, that's a big one. When we're talking about hospitalization, we're talking about duty to warn. Our clients can get very upset when they disclose something and then we have to act. Be mindful of cultural factors. There are some cultures, minority cultures sometimes where they'll be like, oh my goodness, these kids get on my nerves, I could just kill them. You want to get clarification, because that could be a verbal expression of overwhelmed, I'm tired, I'm stressed, not necessarily I'm actually going to kill the kids. So you want to make sure that you are aware of those cultural language that some of the clients may use when we're thinking about breaking confidentiality and making sure that we're assessing that properly. Child abuse and abuse of older and vulnerable populations obviously is something that we would report. And then court orders, subpoena and signed court orders. I'll give you all the example. I received a court order very early in my career And one of my colleagues was, helping me cover and stuff like that, was starting to like get the records together for this court order that came through on the facts. And when I looked through it, it wasn't signed by a judge. So technically it was not valid. It was a mistake that the signature wasn't on it. But the colleague, being helpful, just started gathering records to send without actually looking to make sure that signature is on the court order. It has to be signed by a judge. You cannot just get a court order and respond to it. It has to be signed by a judge. And you want to be mindful of that, because when you get a signed court order, you're bypassing the client's right to confidentiality and doing what the law requires. So you want to make sure you have all your ducks in a row when you're doing that. Any questions about either this slide or the last slide that I just went over?
Well, Martha said, just based on the information that you had just shared on this slide, specifically when using interpreters, this is really important.
Yes. And then also there should be some type of agreement between the interpreter and the agency that kind of bounds by confidentiality. You shouldn't just get one just like off the street. Now, the client does have the right to bring in interpreters from like their family or support network, which sometimes clients do prefer when we think about cultural dynamics when it comes to treatment access. If their language is not English, sometimes they'll bring an older child in or a relative that does speak English and translate. Get a release form for that person. They'll get a release form and make sure that the client understands that as well. You don't want that person just coming in. Also, if they have any emergency contacts, I automatically get release forms for them too, because you just never know when you'll have to contact them. You don't know when relationships may shift between the client and those entities, and you want to make sure you're just covered. Even if you never have to access the emergency contact, it's better to just get it and never use it versus you have to use it and then the client feels as if their rights were violated as it relates to confidentiality, and you don't have anything in writing giving you permission to contact that person. All right, any other questions before I move to the next slide?
Norman said it should be addressed again with the court once they have completed intake and a new therapist is assigned.
Oh, absolutely. Absolutely, absolutely. And when we're dealing with the court, sometimes they will refer clients for services. You want to make sure, I think somebody asked this question before the break, you want to make sure the client understands their unique situation, because even though we may say release forms, confidentiality, they may not have those same privileges in the legal system. We are not legal. Everything is the client's decision. When they're dealing with the courts, they don't have those same rights. So you want to make sure the client is really informed, particularly for those that are on probation and parole. When it comes to those mandated clients, part of their probation and parole, they sign a release form for all providers and stuff for like the life of their probation and parole. And I've seen some that are like 10 years old, but it's still in effect because the client's in probation and parole. So it becomes sticky when we think about the client revoking consent because they think they're going to get a probationary violation for like a positive drug screen. So you want to make sure that you still give the client the right to do a new release form in accordance with agency policy, but understand that if you revoke access to your officer or your attending professional who's overseeing your mandated status, then that could have legal consequences. It doesn't have consequences for us, but it may have legal consequences. And you want to encourage them to discuss that with their support persons or with that mandated professional that's overseeing their case so they can make informed decisions throughout the service delivery.
Mm-hmm. Renata asked, what about when a 15-year-old that brought her best friend to a session?
Best friend as in parent or best friend as in another team?
Renata,
it was not a language, it was just her best friend had slept over in her house, and she said, I want her to be here for me, and she knows everything about my life. So I not do a release, like I don't know if I supposed to have signed a release for her.
Generally, unless this 15-year-old has a substance use diagnosis, because that will be the only time in which they have legal authority to even consent for a release form. So let's say the 15-year-old does not, they're just pure mental health or case management, no substance use diagnosis. Unless that parent has signed a release form, that best friend is going to have to come back at another time, or we'll reschedule the session during times when we can maintain confidentiality and privacy. If that 15-year-old has a substance use diagnosis and they have the capacity to give consent, they're treated as adults at that point. So we would bring out a release form, get them to sign without that best friend present, so there's no coercion, and they would sign that release form, and then we would proceed as usual. So it really depends on if they're a substance use disorder minor, and if they have the cognitive capacity. But if that is not a factor, then unless that parent has given consent, then we either reschedule the session, or we ask the client to have their best friend step out and we can meet privately. All right, any other questions before we talk about when you can break confidentiality? Nope, okay. So when can we break confidentiality? And I won't spend too much time on this one because I think we all kind of know this one. So when you must warn others of possible harm by the client, do your due diligence in this one. You don't want to over disclose. You just want to share just enough for that person to protect themselves. And then also you want to still protect the client. You don't want to just call and say, hey, Johnny made a threat of homicide today, and then Johnny just walked out of your office. If you're making these type of phone calls, you've protected the client. So usually that entails hospitalization or some type of level of containment to stabilize the client, and then you warn as well. You shouldn't just warn and just let the client just go out into the community. So the client needs professional services and cannot obtain them voluntarily. And this is a really good example of when their psychiatric symptoms have gone beyond their ability of maintenance. So when we're thinking about hallucinations, delusions, we think about a reduction in their daily life skills to the point that they are no longer able to maintain their independent living. They're suicidal, homicidal, those type of things, and the client cannot obtain consent. Whenever we're doing hospitalization, it's best practice to try to get the client to go willingly first. But if they're not able to do so, and they, obviously the threat is there, then we have to do it involuntarily. It's important if we do it involuntary that we follow up with the client once they've come out of hospitalization and they're stabilized and repair that relationship, because it can really be seen as punitive, violating. I disclosed something to you and you put me in the hospital, and we don't want to come from a do it the way I said it, or this is why I had to do it. You really want to understand the client's feelings of betrayal, even though they may not always be fitting to the situation, but you really want to try to understand those feelings and help the client navigate that, and make sure they understand our role is to protect them, even if it's from themselves. So when protecting clients from harming themselves, which I just kind of tapped on, if you're attempting to obtain payment for services, so let's say you're calling an insurance company and you're like verifying member ID, or you're resubmitting claims, you don't need a release form to do that. You can contact the insurance companies or the payer source and kind of have those conversations. You don't want to talk about, unless it's like a peer-to-peer review, which sometimes insurance companies would do to make sure that the services being rendered are appropriate for the client. Unless it's something like that and you're calling just to like verify insurance, it should just be demographic, member ID, who's the subscriber. It should be very limited. You don't want to over disclose, but there's sometimes the insurance will call to do a peer-to-peer review because maybe the client may have been in services for too long or something, and they just want to make sure that the client has not reached maximum benefit. In those situations, you can still break confidentiality. I sometimes will let the client know that I'm doing a peer-to-peer review, just in case that reviewer reaches out to the client to kind of get their perspective on things, and the client's not blindsided. Like, who are you? Why are you calling me? Like, you want to make sure that if it's appropriate for the client to be involved, that they're aware of that. But you don't need a release form to engage in that process with managed care organizations, which is like our insurance companies. So if you're obtaining a professional consultation from your regular supervisor within the regular course of supervision within your agency, you don't need a release form for that. You can engage in individual and group supervision as appropriate. You do need a release form if you're talking outside of the agency and the client can be identified. Then yes, you do need a release form. All right, any questions about this slide? Nope. Minimum necessary rule. So what does this actually mean? We only release the minimum amount of information needed for the other agency to fulfill their responsibility to the client. So there are some laws that allow us to put multiple service providers on one release form, particularly the 42nd CFR. That's a new change that's put in place where we can put multiple providers on one release form. I, for the purpose of this service training, do not recommend that. I recommend you get one release form per provider, even though the law allows you all to do that. Ethically, I feel like it creates a window for over disclosure. For an example, if I have social services, if I have their addiction treatment agency, if I have their employer, let's say they're in like an employment training program, all in one release form, and I'm checking the boxes on what can be released, how do I know that their drug screens that were supposed to be released only to that addiction treatment agency now are able to be open to that employer? You know, and the way I was always trained is that when you're sending client records, you always attach the release form with a fax cover sheet with whatever it is that you're sending. So whoever is receiving that, they know the fax cover sheet, who is supposed to code to. We have that little statement at the bottom about redisclosure. And then we have the release form basically saying at this point in time, the client gave me permission to send you whatever the records are. When you have all those providers listed on one release form, let's say the employer wants to know if the client was in services that day because they missed work or something. We may attach a note that says, yes, they were in services today. And then we put the release form and then the fax, right? Just the release form having those other providers up there, now the employer knows the client is in addiction treatment. Now they know that they get services from social services. So it's kind of like creates over disclosure unintentionally. So even though the law allows us to put multiple providers on there, I personally, for the sake of this training, just go to the old practice of one release form per provider. And that way the client can check off what box is specific to that provider or entity. And when you're communicating with them, the permissions are specific to them. It also makes it easier when you're revoking consent, because of course we'll do a progress note stating that, you know, the client revoked consent, and then we'll take that release form and write revoked in big black Sharpie marker, the date and time, and we'll scan it back into that record so that it overrides the one that was in place before. If you have all those providers on one release form, you've now revoked for everybody and it just becomes messy. So just having one release form per entity, it's cleaner to track what needs to be disclosed to who. And it also allows us to enact the minimum necessary rule, which means I'm not over disclosing by even saying that client gets services from there. If we're dealing with a medical situation with a client, because sometimes there are medical emergencies that occur while the client is in our care, you still have to enact the minimum necessary. So if the client is having, you know, an overdose or other medical challenge, we will only release medical records related to their health. If they have a substance use diagnosis and we suspect it's an overdose, you will only release that. You may release their emergency contact and maybe their demographic information to the EMTs. You would not say, you know, they had a, you know, child, you know, molestation history in the 5th grade. That's over disclosure. You would not disclose anything that's not related to that medical emergency at that time. Are there any questions about the minimum necessary rule? Nope. Okay. So let's talk about standards of practice as it relates to informed consent. So information which enables the client to make informed choices, information to promote cooperation and participation. The client, in order for us to say informed consent was enabled, they have to have the capacity to give consent. They have to be able to comprehend the information that we're giving, and they also have to be voluntarily. We want to make sure that they're able to give that voluntariness. So if the client is not able to sign without coercion or pressure, we don't want to say it's informed consent. If they don't understand the information that we're giving, then that's not informed consent. And we want to make sure that they have the capacity to make clear and competent decisions. While they're going through a psychiatric crisis, that's not the time to say sign a release form, because they're not able to give that capacity and that comprehension at that moment. All right, are there any questions on this slide? Nope.
I don't have any questions. Norma did mention that there are some CSBs that have multiple party releases, and this kind of goes back to our previous conversation as well.
Yes. All right, so now let's talk about privacy. It's very different from confidentiality. And again, I kind of touched on this one, so we'll kind of zip through this one. This is the right of the client to choose what others know about them. So whatever the client holds, to their chest and doesn't tell us, it's confidential. Well, I mean, it's private. Once we know about it, then it becomes confidential. Client privacy can be invaded by their insurance company, and you want to make sure clients are aware of that. If at any time their information is being accessed without a release form, which is through subpoena, court order, or through MCL or anything like that, and you feel like it may impact the client, you want to make sure the client is aware of that so they can make informed decisions on how they want to move forward. Privileged communication. Confidentiality is not the same as privileged communication. Privileged communication has to have 3 components. The material cannot be divulged in court. It has nothing to do with the agency as itself. It's strictly within the court system. There has to be a protected relationship, which means there needs to be signed contracts, assessments, treatment plans, we call them legals, but there has to be documents to showing that this is a relationship. I am your practitioner, and this is where you've consented to services. We went over our privacy. There has to be documentation to show that this is a relationship professionally between me and the client. You have to have permission from the client to share. Normally, if clients are choosing not to have things pulled into the courts, I will have them put that that decline and revocation in writing. Put that in writing, and we have the request, but then we also have the client's response to that where they have evoked privileged communication. And unless we get a subpoena or a court order, the client's word is what we go by. All right, so privileged communication criteria. Again, communications must be confidential, which means they must have been disclosed within the context of the relationship. You must be a licensed practitioner. You can't just be someone that's just kind of just doing whatever. You have to be licensed, which means there's ethical codes and there's certain protections about the client practitioner relationship. Their communication must have occurred within the context of treatment delivery or diagnosing. Like it has to be within that context there. And you should all be aware of state and federal law, because again, here in Virginia, court orders and subpoenas bypass that, but in other states, the laws may be a little different. So you want to make sure that you're aware of what our requirements are. All right, mandated reporting. Again, you want to know federal and state laws. Most of us already know a lot of this. I won't spend too much time on this, but we are required in the state of Virginia to report abuse and neglect of all vulnerable populations. And I'll just use that as a catch-all because that's adolescents, children, minors. It's also older vulnerable populations. It's also incarcerated populations. That it's a catch-all for that. Physical abuse as well, psychological maltreatment, abusing our clients in the course of their psychological treatment, and then sexual abuse. So it's not just us doing it, but any time of suspected. We do not have to have proof. We do not have to have proof. As long as you make a report in good faith, you are covered. Emphasis on good faith. It should not be punitive. It should not be a threat. If we suspect any of these categories to be present within the course of our services that we're providing, we are required to mandate report them. Now, this becomes a gray area because sometimes when we're dealing with minors, I'll get questions of, should we tell the parent that we're calling CPS? Or should we tell this person that we're calling and mandating reporting? I always say, going back to benefits, is it benefiting the client? So if we feel as if the client will be harmed by that parent knowing that the client disclosed something to us, do not tell the parent. That is a courtesy. You are required to mandate report. Your client may be that minor child. And if you feel as if that parent, and this is suspicion, you don't have to have proof of it. If you feel as if that child may be harmed throughout the course of the investigation or 24 to 48 hours before a CPS follows up, Telling the parents is a courtesy. Our job is to protect the client. So you do not always have to report to the client. And if you are questioning that, that is something you can discuss as you're making the report, how to move forward with that. But you are required to report. We cannot just work with families and kind of sweep things under the rug, because that would be unethical, and that would be acting morally and not necessarily ethically. All right, I don't see the chat going up, so I'm assuming no questions. All right, so confidentiality and record keeping. So clinical records should be maintained and utilized in a private and secure manner. Pretty much everybody uses electronic health records, which I love because it's timestamped. You can see who accessed what. Educational records in FERPA, you want to be mindful what the laws are for those if you are working in an educational setting. And they're pretty similar to HIPAA, but there are some guidelines for parents to access different things. 42nd CFR and addiction, I kind of touched on this a little bit there. The 42nd CFR does apply to school settings. You're not exempt from that at all. Court-ordered records, you have to comply, with those, but you want to make sure it's a signed court order, because when the law comes in through subpoenas and court orders, you're bypassing the client's right to confidentiality. So if you have to do that, you want to make sure that you have the documentation to substantiate that, just in case the client comes back and complains. Signed releases, again, release forms should only be good for a year at the most. They can be less than that depending on the time you're putting services in place, but a year is the max. And you want to make sure that the client knows that just because they have a release form in place, it is not a permanent document. They can always revoke it at any point in time. The 42nd CFR allows clients to revoke consents verbally and in writing, and that's only for clients with substance use diagnoses. For clients with just straight mental health, that revocation has to be done in writing. Now, if the client revokes it, and let's say the next day they change their mind, they have to come back in and put that release form back in place in writing. All right, so for the sake of time and for us to start lunch on time, I'm just going to get through these next couple of slides. All right, so confidentiality here. Typically, parents and guardians will give consent to treatment on the minor's behalf. You want to make sure it's the custodial guardian. So birth certificate, copies of court custodial guardianship paperwork. These are things that we can use to verify that the person who is consenting to services is the one that actually has the legal authority to do so. So that's really important. Possible exceptions, obviously if the person's married in armed services, or they're being treated for substance use or sexually transmitted diseases, and they're minor, usually if they're married and stuff like that, they're probably emancipated. In those cases, then the minor can consent. They can access substance use disorder and medical STD treatment without the parent's consent. So you want to be mindful of that. It's good practice to get AFENT, which is like a special consent from minors. So even though you get the consent from the parents, it just kind of adds that buy-in for the minors. So you want to make sure that you consider the client's level of understanding. Obviously, you wouldn't be doing this for a 6-year-old. You want to be sure that they have the ability to understand cultural implications there. And then, of course, with FERPA, when we're in the school setting, there are certain guidelines that are specific to the schools. All right, any questions? Nope. All right, confidentiality and technology. So our ethical codes for all professions require us to take precautions to ensure and maintain confidentiality with all of our records, making sure that when we're typing our notes, a lot of times we log into our electronic record system. Sometimes it'll pull up our whole schedule for the day, making sure your screen is not facing clients, position your office to where the client is not sitting behind you when you log into your computers and stuff like that. When you're doing distance counseling via telehealth, you want to make sure that the platform that you're using is going to be compliant with HIPAA and FERPA and not allowing people to have access to that. Social media, a lot of our ethical professions are putting things in place to ensure that we're not developing dual relationships via social media, not posting pictures of our clients, because again, that's disclosure of who's getting services. Using technology in the helping profession, it's just making sure that we're storing records appropriately appropriately, we're transmitting them appropriately during encrypted means, that we're retrieving data properly, storing them, making sure we're not just leaving them on the fax or anything like that. There are limitations of confidentiality when using electronic records, and you want to make sure you discuss those with the client. So if you're using like a portal and there's like an email address associated with that, making sure the client knows that only that email address can access certain records. So a lot of this is based off of the technology that's within your agency, but you want to make sure when the clients are doing informed consent for services that you have a little blurb about telehealth if your agency provides telehealth options, that they are consenting to telehealth. It is a big thing since COVID, so I really do strongly recommend everybody take training in telehealth work and screening and assessing and service delivery. There is credentialing, and you can become a certified telemental health provider. That's something that's newer coming out. So again, it's just a really good testament to, as our field evolves, the technology and things evolves with it. All right, so I still don't see the chat moving, so we're just going to move along. So we're now going to talk about boundaries, dual relationships, and gift giving. So dual relationships, we should not be servicing our friends as a client. So if they're our friend first, they should never become a client. If they are a client, they should never become a friend. We should never provide services to our colleagues. It just creates a really imbalance of power, particularly if we're in leadership. We don't want to say, oh, I can provide counseling to you in my private practice. So we just don't want to do those dual relationships. So this is when we have more than one relationship with the client. I get this question a lot, like if you change agencies and let's say that client just comes to that new agency, that's not considered a dual relationship. Dual relation, because it's still a professional client. I'm referring to clients coming to your birthday parties, or clients spending a night at your house, or clients becoming our romantic partners or our business partners. These are really defined relationships that are overlapping, that are clearly conflictual, and also challenge our objectivity. So you want to avoid them at all times. They are 100% exploitive. When it comes to ethical dilemmas, dual relationships 100% will be seen as you exploiting the client, regardless if the client initiated it, regardless if the client was completely consenting to it. As an ethical board, it's 100% of the time seen as exploiting the client, and the responsibility is on you as the practitioner. Our clients are not bound by our ethical codes. We are. So if they find us attractive, yes, they may hit on us. Yes, they may ask us out for dinner or lunch or offer to go to the movies. It is our ethical responsibility to decline and to really explore that client's need for attachment and how that's being confused with the clinical relationship. So when the client initiates that, I like to look at it as a clinical opportunity to really explore the client's need for attachment and why they can't get that met outside of the clinical relationship. So it's a really good learning opportunity if it's pivoted the right way that can actually strengthen the clinical relationship and really get into the client's needs. Receiving gifts, it's best to avoid them 100%. Some agencies do have policies that say you can accept a gift if it's like under a certain amount or something like that. And they're very strict on that. So let's say if it's under $25, but you can only accept it on behalf of the agency, like you can't accept it personally. That may be the agency's rule, but then when you still look at your own ethics, do you really want to be accepting gifts? I think it really comes down to manipulation versus gratitude. Sometimes for myself in play therapy, I'll get artwork from a lot of the kids that I work with. It's not coming from a place of manipulation, but from a place of gratitude or just wanting to feel connected to that process. Obviously, it's not, worth more than $25. So that case, is something that you would accept, but you don't want their name on it and you put it on your wall because the next 5 clients now, their confidentiality is violated. So you really want to look at the intent behind it. If a client has a positive drug screen and then they're asking you, hey, do you want me to wash your car? Then now we're looking at manipulation at that point. It's really important to look at the agency's policy and what that is dictating there. If you choose to accept a gift from a client and it falls within agency policy, it's not manipulation or anything, you document what the gift was and why it was accepted. It really needs to be ethically appropriate for it. So in the example I gave with the children in play therapy, if they have given artwork, I would document that and put that in there so that it's not anything that's kind of like hidden. So are there any questions or comments about this particular slide? Nope. I see someone talking about a year or more. Okay, lots of situations in which they've crossed the line. Dual relationships and dual relationships with our clients, having sex with them and stuff like that, and then confidentiality are actually two of the biggest ethical challenges for our field. And I think it's because we work with our clients so intimately and we have needs for love and attachment, and we're so involved in their lives that if we haven't done our own work, it's easy for us to start forming sexual relationships with them. All right, so I'm going to do one more slide before we go to lunch because we have 2 more minutes. And that brings me to sexual relationships. And then we'll let this be our stopping point until after lunch. So sexual romantic relationships are almost always illegal, completely unethical. I sit on Virginia Certification Board. Sexual romantic relationships between colleagues that have turned exploitive, and then also between practitioner and client are some of the biggest ones that we see. Looking on the board's Board of Health Professions website, it's a big one and it's detailed. One thing I will say is one of the things that would tank your career is an ethical violation. The client's name will be hidden, but ours is not. It is public knowledge, and it's tied to Google and all that stuff. So for clients, the helping relationship may be the first time they have experienced somebody that's listening, somebody that's attentive, somebody that understands them. And even though we're doing it as part of our effective behavioral health professional identity, for somebody that's not clinically trained, it comes off as an invitation to like, you like me, you get me, so maybe we can date. So this is where that obligation to uphold those standards come in. If we are facing difficulties in our own life, a sensitive and concerned client can be appealing, especially if the relationship has progressed to where the client is really disclosing, they show up on time, they're reliable, and it's really like clinically growing. If we're not getting our own ego and self-actualization and need for validation met, it's easy to say, well, this client gets me, so I can spend a night at their house or have them spend a night at my house or something. Or if they make a pass, accept it because they won't tell on me or anything. 100% of the time, it is considered exploitive. You can and will get an ethical violation, which can be revocation, suspension across disciplines. It is just not worth it. When you think about the billions of people that are in the world, you don't want to form a sexual romantic relationship with somebody that's vulnerable, somebody that's seeking services from you, somebody that's relying on you to help them get to a higher place where they feel good about themselves. It really speaks to who we are and our need for validation and our need to feel powerful and dominating over people, and our need to feel wanted when we start forming these relationships with those that are most vulnerable. So with that being said, it is time for our lunch break. So I'm going to stop here. And I'm going to turn it over to our facilitators for our lunch here.
We will be on lunch from 1 until 2. We'll see you back here at 2 o'clock. Once again, you do not need to leave the Zoom room. You can just turn your cameras off and stay here.
And I'm going to answer your question, Jim, when we get back. Hello, can you all hear me okay? Yes, y'all are good?
Yes.
All right, so we're going to jump right on in. We're going to take a few minutes and talk about impaired colleagues, and then we're going to jump into actual ethical decision-making models. So I hope you all have had a really good lunch. I saw Jim ask a really good question in the chat that I want to highlight and give some attention to. So he talks about being an intensive in-home and how sometimes clients would invite you to dinner. And if you're not familiar with intensive in-home, it's a community-based service for at-risk youth where we kind of go into their homes, go into the community with the goal of preventing out-of-home placement. So within that capacity, obviously I love intensive in-home. I used to do it many years ago, but you're in the client's actual lived culture, their home, you're interacting with them in like their actual environment for that. So with that does come some ethical dilemmas, and he presents a really great one about when they like offer you food. So this is kind of like that gray area, and this is a good example to lead into our ethical decision-making models because in any traditional setting, accepting gifts, food and things like that, morally, ethically, it's not a code says you can't eat food from clients, but it may be frowned upon if accepting food leads to other things such as boundary crossing, or maybe the client using their food stamps to buy you groceries. Like it can lead to other things. So to answer his question specifically, where he's saying like, what do you do when you're in their home and the client invites you to dinner? Do you accept? Do you decline? So there's two answers for that, and it really depends on your agency. If you decline, then it can come off as you're not relatable, you're not genuine, you're judging us, you think we're dirty, and then you may start getting some no-shows. So the first thing I would say is consult with your supervisor on what their policy is. If there's like an absolute no, then that is what you'll use to decline. Unfortunately, my agency doesn't allow that, but the food smells really, really good. As an option, why don't you all go ahead and eat, and I'll either schedule before you guys are eating or I'll schedule after. And this is if the agency has a clear policy against that, because again, we don't want to do morally, which says, oh, they offer it, so you don't want to be rude. If ethically in our agency, our organizational ethics prohibit that, we want to make sure we stay within that. But let's say it's not there, because most agencies don't have a policy for food. So what do we do? I always lean towards the side of, would we do it with every client? That's where it starts. Is this organizational culture to do it with every client? Because if the answer is no, then we start looking at why this particular client is an outlier. And then that kind of is a self-reflection on ourselves. So let's say it's the norm, for the agency. Sometimes they'll take the kids out to eat as a reward and all kinds of sort of stuff. So let's say it is clinically appropriate to have dinner with our clients because we're doing night sessions after school hours. I personally will not eat the client's actual food, only because that creates the boundary of you provided a service for me. If there is no ethical code violating that, if there's no agency policy stating that we can't do that, and let's say their treatment plan is on like socialization during mealtime, social skills, manners at the dinner table, like it's something clinically appropriate, to work around that, considering the culture of the family, maybe bring your own food. But make sure you've discussed this with your supervisor. It's documented in the service plan as being something related to the client's goal. And maybe I'll eat with the client, but I'm not going to eat the client's food or have the client eat my food. Again, this is very situational. And there may be times where the client at the dinner table is maybe throwing food, or they're having outbursts or flipping tables. And we're trying to really observe that behavior. It needs to be clinically appropriate, because that is the fine line between gifting and providing me a service and me actually engaging the client in their natural environment. And it's something that can be justified clinically if it ever does come up. But again, the fine line is I'm not eating my client's food. Let's say if they're offering food for that. Me personally, even though I've never seen it being a formal agency policy that you can accept food, I would never accept food from a client on my personal behalf. Now, I have had clients that have had bakeries and they make cakes and pies and that's their business, and maybe they want to bring those things in. If the agency does not have a formal policy against it, then I would discuss it with my supervisor and accept it on behalf of the agency. So what does that mean? If they maybe baked a basket of cookies, I'm not putting it in my personal office and busting out a thing of milk and eating it myself, because then that means I have accepted it personally. Accepting on behalf of the agency, maybe putting it in the front lobby so that everybody has access to it. But you've discussed it with your supervisor, it's documented on what the reason for it was, and it's not going against policy. So to answer your question, Jim, there's not like a set black and white answer. It's very much depending on your organizational policies, ethics. Is it something tied to their service plan? Is it something that's culturally appropriate? And if it's part of their culture, you want to look at the fine line between manipulation and actual gratitude. You know, are they doing it because it's part of their culture and that helps build the therapeutic relationship? And if that's the case, then you would discuss it. I would not accept it without discussing it with my supervisor. If they offered it the first time, I would say, I'm not going to accept it right now because I don't know what our agency policy is, but let me look into that and I'll get back to you for it. So you're not saying like a hard no, but you're not accepting it and then come to find out that there is a policy against it. And then now you've kind of violated what your agency expected of you. And most clients will be understanding, because if they like you enough to offer food, they would be, considerate enough to let me check to make sure I'm doing this right and get back to you. And if the answer is no, then you have an informed reason as to why you can explain no. Did that kind of answer your question, Jim? I think so. Okay. So we're going to jump in. I'm going to share my screen. And that was a really great question. So I wanted to make sure I gave it proper attention. All right. So we're going to jump back in here. Share my screen. All right. We'll skip this one. All right, so we're now going to talk about impaired colleagues, impaired workers, which can be ourselves. Impairment happens. You know, when we think about that, the nature of our work itself, we do not work with clients that are at the best versions of themselves. That's why they're our clients. We deal with the worried well. We deal with the depressed, the anxious, the ones that are having psychosis and substance use and marital issues. Like, we deal with those that are struggling with life on life's terms, and that's why they're coming in for services. So there is a natural burnout factor that just comes with being a helping professional. So considering that impairment is something that can happen in our field. So when we look at impairment, it is in most of our ethical codes. I would say, I would even lean towards saying it's in all of our ethical codes, that when you are unable to function effectively due to substance use, mental health, or personal challenges, you have a moral and an ethical obligation to yourself and to the field to address it properly. And if a coworker becomes impaired, there are certain steps that many ethical codes do outline that we should follow. So first, considering the colleague relationship, you want to address it with them first. Now, I do put a little fine print on that. You don't want to address something with them if it's something that's going to endanger the client. Now, for an example, many years ago, I'm not going to say where I was working, but I was working at a public agency, and a client disclosed something to me that one of my colleagues was causing them harm. I won't go into the details because it would identify who that person is. I did not go to my colleague and say, such and such said you did this. I had to go immediately to my supervisor because of the nature of the allegation and the fear. Now, this was a mandated client through the courts, and my colleague had authority over them where they could have signed a signature, and my client could have lost custody of their kids and did like 10 years of jail time. So considering the fear of retaliation, the nature of the allegation, I had to make the decision of not informing my colleague that this was brought to me because it wasn't in the client's best interest. But let's say that is not the case, and we're just looking at a colleague who's just fatigued, maybe tired, maybe not performing as well, but it's not directly impacting clients. We would start talking to the worker or the professional one-on-one privately, giving them the opportunity to know that, hey, are you doing okay? And that's just part of kind of like supporting each other. Sometimes when we do that and give them that little nudge, that's enough for them to, I got to get it together and do what I need to do. And maybe they'll take some days off. It's not about what you say, it's about your delivery and how you say it as well. Most people, human nature, if we know that somebody is coming from a place of caring, they actually are being genuine, they have our best interests in mind. Most people in the helping field are usually receptive to that private feedback. If we feel as if it's something that management needs to be aware of because it may impact clients, then we would talk to our supervisor and maybe let our supervisor know. We've also talked to our colleague as well, so that way they are aware of that, or maybe let our colleague know that, hey, I had to discuss this with our supervisor. Now, myself being in leadership roles, if I'm bringing something up with somebody that's under my jurisdiction as far as leadership goes, I would let them know I spoke with, your direct supervisor as well. So that way they are aware of who knows this. And that kind of goes back to that embarrassment, who knows my business sort of thing. You want to let them know who knows what. So that way they're not like somebody just walks up to them and asks them what was going on and they didn't know that person know. And then that can kind of cause them to retract from getting help. Do not allow clients to become endangered. Regardless of our relationship with our colleagues, our responsibility to the clients has to be greater. It has to be greater. You can be found liable for negligence, malpractice, if you are aware of certain harms to a client and you don't do anything to protect that client, because it can be seen as you being an accomplice to that situation. So you want to protect your career. You also want to protect your clients as well too. Now, on the flip side of that, if you become impaired, you need to resolve those things personally and promptly. We know the moment we wake up if we're not feeling good. We know what's going on in our personal lives. I like to say that practitioner impairment is similar to odor. We smell ourselves before everybody else does. So we know when things are not right. It's when they become unmanageable that our colleagues start becoming aware of it. And at that point, it's probably been going on for a while and we just been keeping it internal. So when it gets to a point where we know consecutively we're depressed, we're anxious, we're not given effective care, we're not really present with our clients, we're falling asleep at our desk, so many different things that are going on. We have a responsibility to protect the profession and then ourselves. You do not want to work with clients if you know you cannot be effective with them, or if you know that you are impaired in any capacity. It's better for you to deal with it privately than for it to get to a point where a colleague has to approach you about it or someone has to file an ethical complaint. All right, any questions about this slide before we move on? Nope, okay. So let's talk about the duty to warn, protect, and report. So again, we're going to look at our duty to do no harm to the clients, protecting the clients and protecting the community. When we have a clear threat of violence is made, you want to make sure that you state the limits of confidentiality with your client. So they are aware that you're breaking confidentiality and protecting them and protecting the community. You want to consult with the appropriate individuals. It does not have to always be a colleague. Yes, a colleague can be an appropriate consult, but it should not be the only consult. When we're thinking about a threat of violence, we want to do crisis intervention consultation. We want to contact the police if it's something that, is something that the police needs to be involved. If a client brings a weapon or anything like that, you don't want to endanger your colleagues and yourself by trying to mediate it yourselves. These are things that law enforcement need to be involved in. If we have an identified victim or we have a suspected identified victim, you have to do your due diligence and identify and notify that person within reason. Now, there are times where we may not have the contact information for that person, or we may not know how to contact them. them. In those particular situations, we're going to assume that the general public is our identified victim, and we are going to move forward with hospitalization. We're going to move forward with contacting the police department. You don't want to say, well, I don't have enough information on who this person is, or I don't have their contact information, and then the client says they're okay, so I'm just going to let it go. No, it's better to err on the side of getting a crisis assessment, pursuing the hospitalization process, notifying the police, and protecting the general public at large, versus not doing that, and then the public is harmed, we are harmed, or other individuals are harmed. You want to warn despite threats of legal retaliation. Again, the law protects us as long as we are making these warnings in good due diligence and good faith. You don't want to do them as a means of punishment for a client. So clients will say, I'm going to sue you if you do this or you do that, or I didn't mean it or anything. Once a threat is made, we take them all serious. There's no, oh, I was just joking about killing someone when I get home. No, we take every threat seriously. So despite the client threatening to sue or anything like that, you still want to make sure you do your due diligence, proceed with that hospitalization, that consultation, contact with the police, making sure you're documenting along the way the entire time. Now, there does become a challenge with duty to warn when you have people in domestically violent relationships. And I have been in a situation where I had a client that I had to do a duty to warn on the father of her children, and she was pregnant, where this person, the father, was in an active affair that my client found out about, and she threatened to kill him. So of course we proceeded with hospitalization. We warned him about it, but he decided that whatever, she's not going to do anything to me. At that point, we've done our due diligence. We've contacted the police. We've done the hospitalization. We've stabilized our client, and we've warned the potential victim. You want to document that because the victims also have autonomy. Now, in this particular situation, he just disregarded our warning. And when she got out of hospitalization, they got into a domestic dispute. There was no physical harm done, but there was a domestic dispute because of that. That was his personal choice at that point, because it was documented that he was warned that she was in a high crisis state, and he willfully made a decision at that point. So as a practitioner, we can't prevent everything with duty to warn, but we want to make sure that we document, we do our due diligence as practitioners to protect the public and to also protect our clients. You also want to make sure that you put crisis intervention plans as a basic kind of standard treatment protocol. These are very different from suicide contracts, which are usually put in place when the client is actively suicidal. A crisis intervention plan is kind of sort of like a treatment plan, but it's specific to a crisis. They're done at the onset of treatment where the client is of sound mind and body. They're not in an active crisis state. And they're basically telling you how they want you to respond to them at a time of crisis. These are the type of people I want you to call. These are some signs and symptoms that I'm going into a crisis. These are the best coping skills for me. You would then give them a list of after hours emergency numbers, emergency crisis numbers for like psych hospitals, after hours care, stuff like that. And it's kind of similar to a treatment plan because it's not done during the time of an active crisis. So it's not time limited. You can put it in place for up to a year. And this is part of that service plan, but it's a separate document where you and the client have agreed on how to help me during a crisis. You get a copy of it, and the client gets a copy of it. It's a really great document that I encourage all helping professionals to put in place to really inform individually how you want, how the client wants you to work with them during a time when they're in a high crisis state. So outside of everything that I just said, one of the first points I brought up in our meeting today was to obtain professional liability insurance. I cannot stress that enough. It's an added layer of protection. You can get legal consultation. You can get legal advice. If you are facing a ethical investigation through the boards or anything, you can get representation. If you are found liable financially, then they have coverage to kind of offset that. So it protects your personal finances and assets from there. All right, so before we move on to the next part where we talk about actual ethical decision-making models, are there any questions about this particular slide?
I have a question.
Yes.
How do I want to pose this? Okay, so what if there's a situation where this is social media, this is involving adolescents, and it was vague, like they posted just some random pictures of guns and a list of names. That's it.
Okay.
Then once asked, it was denied. But they were involved in the legal system, and the GAL and the courts were informed of this, and they were like, well, we don't have enough evidence. What do we do in that case?
So I wouldn't approach it from a legal side, because legal is way different from what we're doing. If you suspect that the client's crisis mindset has elevated to a point where they are at risk to harming themselves or others, then you would approach it as if the general public is our identified victim. So at a very minimum, I would get a crisis assessment done for hospitalization. I probably would put a crisis plan in place where they, actively say, I'm not suicidal, I'm not homicidal, but these are signs and symptoms of it. You want to make sure that you protect the general public within reason, understanding we can't just contain clients altogether, but you don't want to ignore that either. So this will be a really good time to look at your agency's policy on crisis intervention, but at a minimum, I would do a crisis assessment and maybe look at maybe a psychological evaluation too, to maybe see if there need to be some adjustments to their service plan as well. If there are some underlying areas that we didn't get addressed, maybe in our psychosocial assessments that can be done in a psychological assessment there to see if we can adjust, or maybe if there are some contributing factors, because when you think about guns and all that stuff, that's a sense of protection or self-protection. So what are you protecting yourself from? There's something going on with the client that led to that kind of posting. Is it bullying? Is it a threat to my personal safety? Is it anger?
It denied it.
Did you see the pictures though?
Yeah, well, it was sent by the Guardian. Yeah, but
Okay.
the client denied, oh, somebody hacked my page and posted that. So
I was still
the
at
bottom
least
line
get the
is
crisis.
they were involved in crisis for something else anyway, but yeah.
Okay, so at a very bare minimum, I would at least get the crisis assessment done, because we're talking about the difference between confidentiality and privacy now at this point. So you would do your due diligence, do your documentation of assessment, go over a crisis intervention plan. It's like a standard thing, and document the client declined, the client denied that this going on, and at least you've covered yourself from there. Because clients, and I have found that clients that have successfully committed suicide, they are going to go out of their way to stop us from basically hitting those trigger points to prevent it, because their mind is kind of set on it. So in those situations, you document your attempts to resolve it within reason. We can't resolve every crisis, but you want to make sure that you at least address the things that came up that were areas of concern.
Thank you.
Yes, it would be considered a veiled threat. The challenge, Jonathan, is that we don't have an identified victim. So this is where we would treat the general public as an identified victim, and we would get those crisis assessments done for possible hospitalization. They may not meet criteria for it, but at least we got that assessment done. We put that crisis intervention plan. I would even modify the treatment plan and put a crisis goal in there. And it could be something as simple as Johnny has agreed to follow crisis intervention plan for the next 90 days or whatever, but at least you've covered it in a service plan, you've gotten the crisis intervention plan, and at least you got the assessment for it. And mind you, the client's not giving us information, it's private. It's not like we know about it and we're sweeping it under the rug, because then that is within the realm of duty to protect and confidentiality. The clients have the right to keep anything they want from us private. And that's where our morals kick in as a professional, because we start turning into an investigator and start digging and digging and digging. But if the client has that privacy wall up, we're not going to get very far. So the only thing we have to do is document our due diligence to address with the information we had at that time. All right, any other questions? Nope. Okay, so let's switch over to some common elements of ethical decision-making models. So we're going to talk about 4 models today, but before we get into them, we're going to talk about what are some common themes amongst all of them. So awareness, every ethical decision-making model, sorry, it's been a long day, starts with us having awareness of an ethical dilemma. We have to be aware of it. We can't do our models and start implementing codes unless we feel like something's not right or we know something's not right. We start looking at our personal values and our biases. Is this generally an ethical code violation? Possibly. Or is this our morals? That is where that morality and the ethics kind of come in. You don't want to always do ethical decision-making on morality. You want to do it on things that are legally and ethically bound by our profession. So that's where that awareness comes in. Next, we're going to look at grounding. You cannot identify any ethical dilemmas if you do not have any idea of what's in the actual codes. You need to actually know what's in the codes there. So you have to have knowledge of laws, codes, institutional policies, and procedures. And then when you have that knowledge, you have to say, will any ethical principles be compromised? Is it possible? Is this bringing up some type of weird feeling that stuff isn't right? And then we're going to go into consultation. They all have an element of consultation. I love that about ethical decision-making models because it is grounded in you do not make this decision based off of your own brain. You consult with somebody across the board. You make a decision and then you go back and look at this decision again. Like it's never a linear process. Are there any differing perspectives? What is the impact on you? What is the impact on your colleagues? What is the impact on the agency? When we're considering impact, you always do what's in the best interest of the community and the individual. So if it means that one of our colleagues, it's going to take a hit on something, but it protects our clients, our ethical codes say that our responsibility is to the client. Now, all ethical decision-making models have an element of implementation, and you don't just implement it and are done with it. You have to document, and you have to evaluate your decision and document any outcomes from that decision. Our documentation is lasting for years. So you want to document as thoroughly as possible because something you implement now may not come up to light until 4 years later. And you want to make sure your documentation is so thorough that you can recall your thought processing and all the elements from 4 years ago and be able to defend yourself if need be in a malpractice or negligence case. So when you're thinking about implementation, you want to generate possible paths, explore all of them, look at negative and positive outcomes of every decision, and then select the best one, considering what's going to benefit the client, do no harm to the client, our justice, which is making sure there's no issues with culture and not considering what's in the client's best interest, and then most importantly, making sure that we're not pushing our own values and trying to make the client conform to what we want them to do. All right, so I don't see any comments come up in the chat, so we can just jump right on in right after this one. So what is an ethical dilemma? Let's talk about that first. So an ethical dilemma occurs when there are good but contradictory ethical reasons, and we're taking conflicting and incompatible courses of action. So it's when we have our, things that we aspire to, and then there's something that conflicts with that, something that's not compatible with the day-to-day implementation of our ethical codes or our ethical decision-making throughout the day or ethical practice. Ethical dilemmas can be subtle, and we're going to talk about some examples when we talk about the different codes. It's important to remember that ethical dilemmas do not have one path to resolution. All of us, I think there's like 40-something, 40 plus 49 of us in our presentation today. Let's say we all were dealing with a client that wanted to form a relationship with us that was non-sexual, because we're all on the same page when it comes to sexual, a non-sexual relationship. Depending on our work, depending on how long the client's been in service, we may take different paths. We may, to get to an ethical decision, we may apply a different model. We may consult with different colleagues. So there's no single path to a resolution when we're considering ethical dilemmas. So overall, it is recommended that you explore professionally accepted decision-making models. Again, these are just 4 all-encompassing ones. Each profession has their own individual ethical decision-making models, but this is just kind of like an overarching way to approach the models, just to kind of keep our presentation kind of objective and not just to one discipline here. So we're going to talk about the ethical justification model first. Then we're going to go into the stepwise approach, the values-based virtue approach, and then the integrative decision-making model of ethical behaviors. We're going to talk about 4 of those today. So the ethical justification model was developed in 1984, and it focuses on the core values of who we are as an ethical professional, like who we are in our identity. And there are certain reference points that we have when looking at who we are as a professional and how that translates into how we actually make decisions. So the first thing that we talked about earlier today was autonomy, the client's rights to make their own decisions. We talked about doing no harm to the client, and that's that second point there, what benefits the client. And then we also look at fidelity. And fidelity is just a fancy word for being genuine and trustworthy, which we already talked about earlier, was one of the telltale characteristics. And then justice, when we think about cultural sensitivity and not pushing our own biases and beliefs. So considering these 5 points, we would address an ethical decision based off of the perspective that we're treating all of our clients equally in equal circumstances, and our clients have the right to choose how they want to proceed. All of the decisions we make are grounded in the belief that we are avoiding harm to the client and that we're promoting the client's health and well-being. So I like this one because it's really tapping into that line between morals and ethics where we kind of get our wheels turning. So considering this ethical decision-making model, I like to give the example of forming a non-sexual relationship with a client post services. Because we know sexual relationships within services is wrong. We know sexual relationships outside of services is wrong because it's very clear. But what about keeping a friendship with a client once they've discharged? That is no ethical code that says that. It says sexual relationships are prohibited, pretty much in all codes. So the ethical justification model is a really good one that we would use in that situation where we're not having sex with our client. We're not exploiting them sexually, and they've terminated services. It's not in our codes. It's not illegal. Morally, they may say, hey, you know, I like this client. Let's say it's a minor. Let's say it's a 13-year-old or something. It's really going to pull on our heartstrings, right? So when we're looking at the ethical decision-making model, we look at the client's right to have their own decisions, right? So the client may say, hey, Miss such and such or Mr. blah, 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 can I get your Instagram so we can maintain friends, you know, after that? When we look at doing no harm to the client and what's going to benefit the client, and then also being genuine and trustworthy, and then also looking at our values and stuff, which are those other 4 elements there, we still would not form a relationship with the client. Why? Because we're considering the fact that once a client, always a client. Just because this person discharged at this point in time, just because it is a non-sexual relationship, the chances of that person coming back as a client is very likely. We just don't know what happens in the human experience. So they may end up becoming a client later on. But let's say you formed a personal relationship with that client. Now you've stopped them from coming back to you for services, because let's say you're at the same agency. Some clients like to go back to the same agency that they discharged from because they already have that therapeutic relationship established. And if you are the practitioner that's still working there, they may request to go back onto your caseload. But let's say within that time frame of them discharging, you formed a non-clinical relationship, a non-sexual relationship. You've now removed them from having the option of choosing you as their practitioner. So we are actually doing harm to the client because now they have to restart that therapeutic relationship with another provider. They may not attach to that provider because you're still at the agency and you have a personal relationship with them. So they may just try to work with you after work instead of working with their professional that's in work. So you see in the ethical justification model, we are not treating all of our clients equally, because once our clients discharge, we don't put all 80 of them on our Instagram. It's this one particular one. And it goes back to why we did it. What is it so special about this client that we did that? And that goes back to us and our values and our countertransference and our boundaries. So I love the ethical decision-making model because the ethical justification model, because it's really talking about our core values as a professional. It's not a 1, 2, 3, 4, 5-step model, and this is what the decision is. It really holds us accountable to really living the values we have as a helping professional. And if we're truly doing services that are going to benefit the client, services that are going to be non-judgmental, non-discriminatory, and actually do no harm to the client, then we wouldn't make decisions like forming non-sexual relationships with them outside of services, because we're removing the option of them returning to come back as a client. So even though that is not a ethical dilemma that's in the table right now, we're removing their options to coming back and getting ethical care because we formed a personal relationship. So are there any questions about this model before we move to the stepwise? Nope. Okay. So the stepwise model is one that most people are pretty familiar with because it is linear and it actually has steps of what you do to address ethical dilemmas that come up. So the stepwise approach is commonly applied to a lot of ethical codes. It was developed in 1996, and it is a very detailed 7-step process. Now, whenever you are using this approach, I love it when I am doing approaches related to like confidentiality and stuff like that, because I'll actually put these steps in my note. Like I'll actually put, like I use the Forrester and Davis ethical stepwise approach, and this is each, like I'll put it detailed in my note, especially if I know that this could turn into a legal situation later on. So considering the stepwise approach, you want to identify the problem and gather all information related to it. So it's not just the codes that you're going to gather. You're going to gather any legal stuff, any agency policies, anything that the client reported. Like you're really going to do information gathering on that front end and then identify the ethical concern from there. Step 2, you're going to look at the ethical codes for your profession. So for myself, I identify as an LPC as my primary identity. So I'm going to grab that, but I may not be operating as an LPC in this capacity. I could be operating maybe as an addiction specialist, or I'm working at an addiction clinic as a consultant. So I'm going to grab the policies for the addiction field as well too. I'm going to grab the information from my agency. Like, you also want to be mindful that the ethical codes are not just to your identity. Your job description could create liability and oversight for other entities as well. So gather the one for your profession, but then also look at your job description and the organization you're at, and then get the codes for those as well. So you could potentially have 3 codes that you're considering. Then step 3, you're going to consider the nature and dimensions of the actual dilemma. Like, what is it? We have all the information as to what we're talking about. We have all our codes and stuff that we're looking at here. And now we're just going to really kind of process. Remember that we're not just using our brain. Step 3 requires, this is the time for us to consult with other colleagues, our supervisors, other people, to make sure that we're not compromising anything. During this consultation phase, you do want to document who you are consulting with. It's best practice to consult with somebody in a position of authority. So a supervisor, human rights representative, just anybody that's in a position of authority, because again, depending on what this ethical dilemma is, it may come up in a human rights complaint, it may come up in a ethics complaint against your license or against the agency, and you want to make sure that whoever you consulted with can have the demonstrated competency to give you sound advice during that consultation. So after you've done step 3, you're now going to look at all of the actual options that are on the table there. You're not going to just say, I'm going to do this option here. You're going to look at the positive and the negative of each particular option. And you're not making a decision. You're just saying, this is an option, this is an option, this is an option, and these are the pluses and minuses from there. During step 4, you can also still consult as well. It does not have to be just during step 3, but just when you're really looking at the courses of action, you can consult as well. So once you have decided on what the best course of action is going to be, again, considering what's in the best interest of the client and the community, it allows you to adhere to all the policies that are in place, you're going to move to step 5, which means what are the potential consequences? So we have the positive and the negative of, each decision, but once I implement it, what are some future dilemmas that can come from me implementing it? That's what you're going to consider from there. And once you've considered the positive and the negative, and then what could possibly come after you've implemented, then you're going to make that decision of step 6. This is the one we're going to go with because it has the least harm to the client, allows us to have the most benefit while still adhering to the ethical and legal codes of our profession. And then step 7 is when you're going to actually implement it. So you're going to do steps 1 through 6 before you actually implement it. Through each one of these steps, you're going to thoroughly document. Sometimes I would even put a copy of the codes and highlight which ones were up there. I'll put who I spoke to as far as leadership is concerned. If the client was involved in this decision-making process, then I will put that, the client was involved and what their input was as well too. This is a very detailed process. And I usually would use this process if I'm going to break client confidentiality, if I am receiving a court order or something for a client and I have to go ahead and implement it, or my client has successfully harmed someone and I want to make sure that I'm releasing the appropriate records to the appropriate person. Like there's just so many different areas where this approach is so good because it details each step of the way and ensures that you are still doing your due diligence to the profession and to your client. Before we go to the next one, I want to ask, are there any questions on this one?
I don't see any questions, but I do see Chandra mention that she really appreciates being able to interact with you in this fantastic training.
Oh, thank you so much. I can't see the actual comments. I can just see if like the number of comments. All right, so let's go to the next one.
1 second. It looks like Karen does have questions. She said, do you put all of your ethical decision-making notes in the EHR under the client, or do some go into like a supervision folder? To me, it seems there are certain times that this makes sense, but there might be other times where it is much more about me as the clinician, the brainstorming, possible options, how I come to the decision are all about me as a clinician. It seems it could be inappropriate to put it in the client's chart, which is their medical record.
Correct. And I should have emphasized that. This does not go in the client record. The reason for that, anything you pull in the client record can be pulled into litigation. There are laws that protect supervisory records, employee records. Your detailed notes should be in your supervision. That's completely separate from the client record. You shouldn't even be referencing this in the actual decision. You shouldn't be referencing this process in the client's record, because even referencing it can now open the door for that to be pulled from the supervision. So you put all the details, all the notes and all that stuff in your supervision. Now in the actual client record, you're going to say that that this was the ethical decision based off of the maximum benefit of the client. And if there was an alternative decision that was like kind of like second choice, you can document why it was not made. But I wouldn't go through this detailed process in the actual client record. That is completely separate. So I'm glad you brought that question up because I want to make sure we're not confused on that. All right, any other questions? Nope. Okay, yes, that was a really great question. Do not put this in the client record. Don't reference supervisions in the client's record as well. You don't want to do any of that. Like whatever the outcome is, the final decision, that's what you put in the client's record. But the step for that and all the other options, that's completely in your supervision record. So it's still documented, but it's completely held separate. So in the case of a legal litigation, you have certain protections as an employee discussing things with your direct supervisor and administrators. All right. So values-based virtue approach. So this one here kind of piggybacks off of the first one we talked about, where it says we should not merely conform to the codes, but we should aspire to actually be an ethical practitioner. So this focuses on how and who you should be, not what you should do. So you should be living ethics. So kind of worded this a different way. The ethical codes are going to become your moral codes. We talked about in the beginning how morality and ethics are like completely separate. Using this value-based approach, you are changing your values to align with the ethical codes. You're not necessarily separating them, but you're changing your actual values to align with the ethical codes here. So considering the value-based one, the practitioner will reflect on their own values as they reflect the desire to respect the client. They will change their morals and their values to align with the ethical code. So it's not just a separation, but you're essentially erasing values and morals that you have so that way they only align with the ethical code. So this is more of a virtue based here. And giving this example, this is one that considers morals, it considers culture, it considers who do we want to be. So I like to give the example here of some gray areas that come up in our ethical decision making. So for an example, I worked with a client that identified as Native American, and she was terminating services. She was a wonderful client, had been in addiction services for about 2 years with me. Very wonderful. So in part of her culture, they give gifts as far as like the termination process. So of course, there's no codes that says, yes, the codes say you can't receive gifts throughout the course of treatment, but this client is terminating and this is part of the culture. So considering the value-based virtue approach and me desiring to be, you know, a practitioner that's culturally competent, I would go to my supervisor, mind you, my client and I discussed it before she brought the gift in, and say, hey, the such and such, you know, has another 2 sessions left. They asked, could they bring a gift? You know, what is our agency policy? And what I was informed from my agency was that it had to be under $25 and I could not accept it on behalf of the agency, and it could not be during the course of services. So those were the rules for that. So giving that to the client, she came on our very last day of session. She had already signed everything. She was already basically discharged. She's walking out the door, and she presented these handmade earrings that she had made. So she's within the rules of the agency. Of course, I can't accept it personally. So as a compromise, considering her culture and gift giving as a form of appreciation, it was documented, even took a picture of it and inserted it in her record. But I essentially just put it in a picture frame and just stuck it in our front office desk there. Did not have the client's name on it or anything, but I couldn't accept it personally. So it was accepted on behalf of the agency. So when we look at values-based virtue approach, if we're being someone that is considering the culture of the client, considering the client's way of showing gratitude and appreciation, this client was not court mandated into treatment, so there was no legal things that would have come. The client was informed that I would not be taking it home, I would not be wearing the earrings or anything, and she was okay with that. These were things that we discussed on the front end. So when we look at becoming an ethical practitioner, these are some of the things that we're looking at. Do we just say, no, we can't accept gifts? Or do we go and say that we have to consider the client's culture as part of that? And what are our values? And how do we really want to live those values? All right, any questions on this one?
And so Hank says this values-based model seems to me, it could be kind of difficult to manage if a clinician wasn't being faithful to the model. If you were in a supervisory role, how would you handle a clinician who feels as if they are a virtuous provider, but has concerns with their clients?
Okay, so values-based one is not one that is for the faint of heart. It really requires it really requires someone to really have a lot of transparency, a lot of self-awareness. And for me, I don't use this approach all the time. I don't use this one I actually like the integrative one personally. In this particular situation, my value said, okay, she's terminating. I want to at least check and see what our policies was. That's the value one. My value says conform to what the agency says, conform to what the ethical codes, but also considering the fact that the client made this request. I also am looking at the client relationship between she and I. If she was one that was court mandated, if I knew she had a court date coming up, it would have been a straight no, because my values will say, I don't want to be in a situation to where the client can say, I accepted a gift, and then now that comes and questions my integrity when it comes to my documentation and my reporting later on. So someone that is truly values-based is not even going to consider accepting that without looking at the long-term consequences or how it can be translated to the client. Now, if this was a client who had made passes at me for friendship and things like that, my values would say that this could be interpreted from the client as friendship. So then the answer would be no. So it does become a situation where that practitioner has to have a lot of self-awareness. They have to be comfortable within themselves. And the first thing I did was consult with my supervisor. And that's the pivotal part there too. Once the client brought it up, I didn't just keep the conversation between the client and I. And I should have added this point in as well, that when I was discussing it with my supervisor also came in and met with the client and I and made sure that this was not, something that would have been interpreted differently. So it's definitely a collective approach. It's not something for someone that's like new in the field because they haven't really developed their ethical identity enough to be able to say, I'm able to wipe away my morals and my values. They probably would have wore the earrings because they were nice or something like that. So this one is more for our senior professionals, our professionals that are very versed in ethical decision-making, very grounded within themselves. They're able to kind of really separate that practitioner-client relationship and really kind of consider the holistic parts of the ethical dilemma. It is definitely not one that I would recommend for entry-level individuals or individuals who are struggling a little bit with ethical implementation. All right, any other questions?
Thanks for the explanation, he says.
Okay. All right, so this particular one, which is the last one we'll be talking about here, is the integrative decision-making models ethical behavior. So we highlight the need for the practitioner to review all decision-making in light of not just codes, but also cultural, social values and context. So we're going beyond just, this is what the code says, this is what my agency policy, and this is what the law says, but we're also incorporating the client's view in there. So when we look at step one, we're going to interpret the situation through awareness and fact-finding. So when we say awareness and fact-finding, it's not just what I think the situation is. It's also what the client thinks the situation is, what the client's culture is, what is their intention behind it. And that's a discussion. I've had clients that would try to give me like Christmas cards and they'll be like, hey, can you accept this Christmas card? And that warrants a discussion. Do you feel obligated to give me a gift because we work together? Because if that's the case, I want to alleviate that obligation. You don't have to give me a gift to acknowledge, our awareness, our relationship just because it's Christmas time. So you want to interpret the situation through your awareness, the client's awareness, and then do fact finding as well. And by fact finding, you're going to look at the social context behind it. What is the meaning behind the client's intention or what this ethical dilemma may be? From there, you're going to formulate an ethical decision. So this one can be kind of implemented with like the stepwise one or the ethical justification model, where you kind of really look at all of the elements that are there, and then you're going to make an actual decision, but you're not going to actually act on it. You're going to formulate a decision and then maybe look at alternative decisions as well and really consider each one. You're also going to consult during that ethical decision, because it's not just the client's culture and social values that we are taking into consideration, it's ours. Am I acting in a biased way? Is my judgment compromised? Is this a moral decision, or is this one that I'm really making that is ethical and that any other person in my position would be making the same decision? So it's really reflective of our own culture, our own values as well, and in making sure that they're not influencing how we go through each one of those steps. So once we have done step 2, you're going to consider step 3, where we're going to select a course of action and weigh competing non-moral values. So what does that look like? We're actually going to ask ourselves, once we've made a decision, is this a decision I'm making because I'm mad at the client? Is this a decision I'm making because I feel sorry for the client? Is this a decision because I'm trying to prevent the client from getting natural consequences in the legal system? Is this a decision that I'm making based off of morality? That is part 3. We're looking at our non-moral values and how they may be influencing how we go through these steps to make an actual decision. And once we have considered the best course of action where our morals are not kind of jeopardizing it and it's truly in the best interest of the client, we've consulted, we've done all those steps, then we're going to execute our actual decision, and then we're going to document the impact of it. We don't just do a decision and then that's it. You're going to document the impact of that decision from there. If you have copies of any reports that you sent off, not necessarily the steps that you've taken, but that final outcome. I like to use the integrative decision-making model when I'm dealing with like the legal system, and sometimes clients will say, I don't want you to report this, or I don't want you to report that. But then I end up getting a court order, and I have to do it. I'll use this step and say, do I let the client know that a court order came in? Sometimes, yeah, I will say yes. But then sometimes I won't let the client know that a court order came. Why? Because my client may skip and run and evade the police and evade probation and parole. And sometimes I'll have to question if me notifying the client is because morally, I feel obligated to tell them like, hey, you told me don't release these records, but I got a signed court order like 4 days later, knowing that this client is a flight risk. That is when this decision-making model would come in. Do I tell them that this court order came in, especially if the probation officer let me know that in confidence? Like, hey, we're doing a violation, just giving you a heads up that they won't be making appointments for the next 30 days or anything. I wouldn't give my client the heads up. Yes, I will follow through with the court order because that's what I'm obligated to do. But that part of notifying the client, knowing that they may skip and they run and they may not go to court, that's where this one kind of comes in. Do I let the client know, which morally is, give them a heads up, but then that's immoral. That's not ethically, and ethically is not in the best interest of the client to do that. So this one is a really good one when you know what the outcome should be, but then there's like those little subtle dilemmas like afterwards, and it's kind of gray, murky areas, but you want to make sure you document whatever the end result is, no matter what ethical decision-making model you choose. You want to always document what that end result was. As you go through those steps, you want to put that in your supervision records. Do not put it in the chart. You want to keep it completely separate from the client chart and put it in your supervision chart. All right, any questions about the integrative decision-making model? And I will give you guys copies of the slides today, and I have all my notes underneath every slide so you guys can get more information on each one. All right, so now let's look at benefits and limitations of ethical decision-making models. Of course, some benefits is that they can help you avoid most ethical violations, allows time to think, and allows you to decide the best course of action. There are some limitations in crisis. In a crisis situation, you may not have the benefit of time to be able to kind of dissect through each step or anything. You want to also consider the fact that most models have been developed from one cultural perspective and also applied to the worldview of another. So you want to consider those cultural limitations, which are some things we'll talk about tomorrow, and that the ethical decision-making models are not sufficient by themselves. You need to have an understanding of ethical principles and then also morality, so you can really get an understanding of when they are overlapping or when your morality is kind of clouding your ethical decision-making. All right, some other challenges to ethical practice. Our ethical codes are guidelines. They're not a clear cut, this is the solution. They're just guidelines. They can be complex and complicated sometimes. Sometimes they're fluid and they don't clearly address everything that comes available or comes up. It's important to remember that we are to be responsive to our client. Our codes cannot always be fully prescriptive or directive. They may not always have the answer. Sometimes they are hard to enact when we're dealing with confidentiality, boundaries, or informed consent, which is why consultation with our supervisors and colleagues and in legal situations with attorneys are important. And then you also want to consider the setting in which you work, as well as the chronological and developmental age of your client when they bring ethical concerns to us. All right, some common misconceptions during ethical decision-making, and I believe this is our last slide before we wrap up. During crisis interventions, you may not always have time to work through each model step by step. So in those situations, you want to make sure you protect the safety of the client. That is always going to be imperative. The safety of the client, the safety of the public. Once that is secured, that should be able to buy you some time to be able to really decide ethically how to move forward once the crisis has been alleviated. The severity of the crisis may not allow you time to consult before you take action. And then also during a crisis, there are lots of factors that may come up where there's not one clear, concrete answer. And then your role as a mental health professional or behavioral health professional is to ensure safety, to be calm, to be collective and have self-efficacy, to be connected to the client and still hope. Crisis interventions do not always occur just with the client. Sometimes it's also with other people around them. So during a crisis and you're trying to make ethical decisions, don't just focus on the client, look around the client as well when it comes to safety and other concerns. All right, so I believe this was our last slide before our questions for breakout, which we can kind of give for homework. And for the sake of time, I think we have like right at 3 o'clock. These are just some questions I want you all to consider as we close today and come back tomorrow. What have you learned about yourself as a helper as it relates to using the code of ethics? Is there a difference between practicing ethically and then being ethical? Like being ethical versus just practicing it. Is there a difference? And then after listening to this presentation, what standards of an effective ethical helper do you feel you will start incorporating or continue to incorporate in your daily practice? So I am going to stop sharing now because we're right at 3 o'clock. And I guess we will open it up to our facilitators on closing us out.
Yes, no, thank you so much for this really good presentation today. It was definitely engaging and enriching. I want to thank everyone for participating, actively engaging in discussion and asking some really good situational questions. We definitely look forward to seeing everyone tomorrow morning at 10 a.m. to, work together, engage in, exploration and discovery and continuing this journey. So again, thank you on behalf of the Office of Child and Family Services. Definitely everyone have a great day.